And when I walked into Grady, it was just there. When you walk in most trauma centers, they're just there. You don't usually have to start a trauma center, and usually it's because some university wants it, not because advocacy demands it. On the opening slide here, you can see the CCD, which is the Center for Care and Discovery, which is the main hospital. You can see it's on the beautiful University of Chicago campus. If it wasn't for COVID, I'm sure you would have gotten a tour, but on the 7th floor of this building, this is a surgical waiting area. You can see it's very open. It's very nice. You can see there's a grand piano. Actually, one of our anesthesia colleagues, Dr. Gottlieb, plays beautiful music on the piano, so please have him do that if you ever make it here. If you look at the top picture at about the 1 o'clock position, you can see there's a dining facility, and out in the back of that, you can make out the famous Chicago skyline. So you are looking from the south side of Chicago towards the north. So here's a view of what that would look like if you were actually sitting in the hospital here at the University of Chicago. Again, for those of us who have been here, you can see the famous skyline. You look out in the water, you can see the Navy Pier. But most people know Chicago from that skyline. They don't know the south side. They don't know that there's a university sitting down here on the south side of Chicago. So at the bottom of the screen, you see this kind of Hogwarts Castle looking kind of building. That's the undergraduate campus at the University of Chicago. At the very bottom of the screen, you'll see a row of trees that is known as the Midway, and that runs east to west. So again, you're looking into Chicago from the south side, and this may be the first view that many of you have actually had the south side of Chicago. This pictures will keep coming up because it's important as you recognize that this building, this famed institution, sits solely on the south side of the city, poised to take care of patients on the south side, but for many years did not. And again, it took advocacy to lower the drawbridge of this castle to allow the citizens who were victims of intentional trauma to come back into the building after an absence of 30 years. So unfortunately, despite the beautiful skyline, this is what happens to the south of the Midway, just in about 4 blocks from us. Intentional violence, young men gunned down, grieving families. If you look to the cartoon on the inset, you can see that this is a density map. If you look at the red dots and the lighter red dots, these represent the concentrations of homicides around the Chicago area. And you can see that there's a good smattering of those red dots and light red dots here on the south side of Chicago. And again, like the images of the skyline, you'll see these density maps show up throughout my talk. I'm going to go to Flint, Michigan. Hopefully, nationally and internationally, we all know the story of the water crisis that took place in Flint, Michigan. This is my good friend, Mona Hanna-Atisha. Mona and I met when I was a trauma fellow at Henry Ford Hospital. And in my first year, we spent our time in Flint, Michigan. Mona was actually the medical student on my service when I was the fellow. And she returned back to Flint, Michigan after graduating from University of Michigan to work at Flint and devote her life to taking care of children there as a pediatrician. One of the things that she did is she stumbled upon something that we knew when we were a fellow and medical students respectively, that you don't drink the water in Flint. That was known long before the rest of the world knew about it. And we knew that children were dying young. We knew that people were getting cancers that were not breast cancer, colorectal cancer, or lung cancer. They were getting atypical things. And we knew that it was environmental because for many, many years, Flint was the home of the automobile, and there was unregulated dumping in the Flint River for many, many years. So, but who was at the receiving end of this healthcare disparity, this economic disparity, this environmental disparity? It was the African-American community. So Mona decided to take advocacy to the legislative branch of governments. And of course, if you remember the 2016 elections, you had every major politician stopping through Flint, Michigan. If you look at the little line I drew here, this is where I lived about 15 miles outside of the city called Fenton, Michigan. Very nice suburb. Just traveling 15 miles out of Flint, Michigan to where I lived in Fenton for 3 years, the life expectancy went up 15 years. If you go all the way down to Ann Arbor, one of the most famed public institutions in the United States, you can imagine life expectancy goes up even further. And to ask these children and the citizens of Flint, Michigan to navigate their way to Flint, to Ann Arbor to receive an education is like asking them to cross Lake Michigan. So not too difficult, not too different than what we see on the south side. On the far south side of Chicago, asking someone to get to even downtown. Many kids have never seen downtown. And of course, on the other side of downtown, you have another famous institution, Northwestern University. Ask them to get an education there is not heard of. But ask them about the violence in their neighborhood. That's a lived reality for them every day. So here's this density map again. What you see is a smattering of black dots. And this is 2014. These dots represent homicides. And if you see the squares with the red inside of them, these squares represent level 1 trauma centers. So what you can see to the south and to the west in a suburb, you have a trauma center, and you can see this concentric circle represents a 5-mile density. They barely capture trauma on the south side. So you see University of Chicago over here with a yellow dot. For many years, the University of Chicago was just a pediatric trauma center. And the pediatric trauma center is not open 24 hours. There's no in-house surgical service. The anesthesia service is already stretched, taking care of emergencies on the adult side, interventional radiology, and has to every now and then go across the street to take care of children. But if you are living on the south side of Chicago, far east and south, you are what's called a trauma desert, in that you do not have a trauma center within 5 miles. But of course, the University of Chicago, you can see sitting right in the middle of those dots. But again, the drawbridge is up of the castle and no one can come in. So since this is an academic setting, I'm going to just do a couple of questions. I won't ask anybody to raise their hands. I will just kind of give you an example as to where we were and where we have come. So question number 1, a 17-year-old male receives a single left thoracoabdominal gunshot wound. Upon arrival, he has a blood pressure that's 90/70, his heart rate is 100. He is diaphoretic with obvious signs of peritonitis. The best treatment options include which of the following? Of course, a lot of these things are nonsense. Perform an ultrasound, initiate volume resuscitation, and transfer to the nearest hospital, and take the patient to the operating room. Of course, it makes sense, but you got to get to the hospital first. So as I showed you, the nearest hospital on the south side is not the University of Chicago. And this is a story I made the question because this is a story of a young man by the name of Benji Wilson. Actually, turns out he's actually related to me through my wife as a third cousin, which I did not realize until I got here. My wife's name was Wilson before we married as well. Benji was an up-and-coming star. He was being recruited by the Lakers. He was on the phone several times with Magic Johnson, who wanted him to be in the court with him. Benji, leaving high school one day when a lunch break, is gunned down and is shot, and he's taken to the nearest hospital on the south side, which if you look from that window that I showed you, you could see it, but it's not a trauma center. There's no surgical staff in-house. Now, I'm going to try something here. Please bear with me. And I'm going to try to show a video, which is not going to play for some reason here. Let's see. And okay, all right. I can't seem to make that work. Let's go back to the talk. Well, if the shot had played, what you would have seen was a video where the news outlets all around the nation were grieving the loss of Benji Wilson. You would have seen, you heard a quote from President Reagan at the time, who sent his condolences. So here's a young man not involved in what we like to think of being gang violence and intentional violence, but an innocent man gunned down by a 16-year-old in the prime of his career, which changed the trajectory of his family, who should be living well as millionaires who are now still stuck in the south side of Chicago. Here's a young man at 16 who is now out of the hospital, who's now out of jail, who shot him, who is now actually indirectly attached to the University of Chicago, and I will talk about this in a second. But you can see, he says, I'm not the person I was at 16. So thinking about the constructs of the being on the south side of Chicago that led someone with a gun, someone with a bright career to intersect and to lead to tragedies that basically ruined 2 lives in the south side of Chicago. Question number 2, a 15-year-old boy is shot in the left chest and elbow. Upon EMS arrival, he is tachypnic, he has a 30 pulse. The best transport option is transfer to the nearest pediatric hospital, consult the pediatric surgery and the hand service. As I mentioned, if you come here, there's no one here to greet you after a certain hour. Since injuries at the level of the elbow, consult the hand service. Since the injuries at the elbow, proximal control is needed, call the vascular service. These are the type of nitpicky things that existed even if you came to the University of Chicago prior to trauma center about who owned the patient. And of course, the patient gets caught in the mix and doesn't necessarily receive the best care. Since the nearest trauma hospital is not a trauma center, which was the one where Benji went to in the University of Chicago, you take them to 20 minutes away. And that's essentially what happened to another young man by the name of Damian Turner. So I'm going to read the first paragraph because I know it's kind of hard to read it unless you're sitting right up front and close like I am. A few weeks shy of his 19th birthday, Damian Turner, a charismatic youth advocate, so not a gangbanger, not someone living on the wrong side of the law, and an aspiring musician, was gunned down in a drive-by shooting, and he was not the intended victim. And I think the part that gets many of us is 4 blocks from one of the best hospitals in the world, the University of Chicago Medical Center in Hyde Park. So here we go. Here's this picture of the skyline again. You can see the University of Chicago right at the bottom. This is the midway that I showed you once before. When Damian was shot, he was shot right here on the edge of the midway. Here's the CCD, and there's downtown. Had the University of Chicago, well, here's a quote from his mother. "My sweet baby could still be alive today if the University of Chicago had a trauma center just down the street." Now, we could all argue that he would have and could have just died from his wounds had he been shot in the lobby of the building. But the optics for the University of Chicago, the optics for their commitment to the South Side community is not very good when a young man who was shot on the edge of the midway and has quoted one of the best hospitals in the nation lets him die. So really what you have is, as those density map shows, is a trauma desert, where if you are injured African-American on the south side of Chicago, you have little to no access to definitive trauma care. So if you draw that 5-mile concentric circle, look what the University of Chicago having an adult trauma center captures. It captures the vast majority of the shootings that happen on the south side. It significantly cuts down the transport times. Since we talked about military medicine, it is impossible to watch a movie about medics, Vietnam, without seeing transport time being the most important thing to get someone to survive their injuries. So Damian's shootings like the ones that Benji Wilson started the advocacy. You can see Damian at the bottom of this, Damian's mother, who made the infamous statement at the University of Chicago Trauma Center, "My baby would still be alive." The demand for change begins. So the advocacy work of the community begins. You can see people took to the streets. There were sit-ins, there were protests in the lobbies, there was political will, there was dialogue being held. The University of Chicago finally came to the table after 30 years of showing little interest in being involved in trauma care on the South Side. And then victory is won. So here are friends of Damian Turner who saw him die, take his last breath, who were celebrating outside the trauma center, which is behind them, their victory, which now allows patients who have not had the ability to come to Chicago for 30 years to be seen here. So now that you have lowered the drawbridge, what do? How do you start? There is no one at the institution under the age of 65 who has any memory of how to do trauma at the University of Chicago. There is no blood bank. There's no master transfusion protocol as it relates to trauma. There is no institutional memory, as I mentioned. So the first thing you do is you bring someone in. My boss, Dr. Rogers, who made his living studying these inequities, just like Dr. Mona Tisha Hanna in Flint, who's looked at the intersection of race, ethnicity, urban trauma care, healthcare disparity, and he's going to bring to the University of Chicago his brand of how we take care of patients on the South Side. And he is the first one in the building. And when he comes to the building, he has to create a trauma team. What someone wants to do is he wants to not only just take care of injuries, he wants to study also the psychology that surrounds the physiology that leads to injury. So we create what's called here, or he creates, and we further that mission with the VRP program, Violence Recovery Program. Its mission really is to have a hospital-based violence program that looks at trauma patients once they arrive to the University of Chicago, and they engage and interact with the victims, the families of the victims, and instead of sending you right back out to be re-injured, we're going to look at the social determinants that got you here in the first place, and hopefully try to mitigate some of the interpersonal determinants that will keep you from coming back again. So Dr. Rogers puts together a team of people. The fat guy with the swollen face is myself, because I spent the summer in Hawaii eating Kahlua pork all summer long. And despite being on a beach in Hawaii and enjoying myself, the idea of coming to Chicago, opening up a trauma center on the South Side that looks a little bit like Afghanistan, was very exciting. Throughout my time here, it has been an amazing journey. As I mentioned, I think they get me. We all brought our different strengths, our different protocols. Everyone in the picture comes from different places, such as LA County, shock trauma, Tulane, Charity, down in Tulane, down in New Orleans. So we really have come here very familiar with trauma, but also, as stated, wanting to bring to the University of Chicago understanding, commitment, advocacy. So we all have our various strengths. You can see Dr. Rogers with his headset on as a leader. There's me over there with the fire in my head. People say that's passion. My wife says it's just because I'm just a hothead. I said that I think it's because I'm cool under fire, because I think I'm cool under fire. My kids disagree with that as well. But whatever it is, as mentioned, the military, getting people here quickly, the South Side, transport time has been a problem. I don't expect you to know this building, but this is a building in Afghanistan and Iraq in 2017. Jeff will get this. Peter will get this. The mission was to go down to the Iranian-Iraq border and stop the influx of IEDs. So a medical unit's going to go down there, and they're going to engage with the enemy. When they need medical support, and we need a building to take care of people. And this is the building that we chose. And no one's asking us, can you do it? Will you do it? You just got to get it done. No one wants to hear about there's plants growing in, there are obstacles. This is going to be your operating room. No one cares about how it looked. You just got to get the mission done. You know, I'm not going to refer to anybody as snakes in the grass in the University of Chicago, but I will say there are obstacles here for people who did not want to see this to succeed. But again, we had to get the mission done. We had rocket attacks. Holes were blown into buildings. We took what we could. We gathered it up. We sealed holes. We patched things. We put in the equipment that we needed, and we were ready to take casualties within 30 days. And you can see this is an example of just getting the mission done. So that became my role when I got here. And again, it was very easy once I met partners like Dr. Tong to do this. But the concept was we really were trying to take a military approach. This is Grady Memorial Hospital in Atlanta, and this is Flint, Michigan. This is Hurley Hospital in Flint, Michigan. We're going to try to shove these concepts into this very pretty, nice building that doesn't do trauma. We didn't get a new building. We didn't get a new trauma center. We're actually going to take the space that existed and make it work. When I first interviewed, I thought this building to the left was a trauma center. It is the parking deck. So you're going to turn the corner and you can look at the bottom of this parking deck, and this is your trauma center. So again, kind of like that building in Afghanistan, we're going to try to make this work. And that parking deck is actually across the street from the CCD. It's not even in the main hospital. So again, the patients on the South Side feel like an afterthought. But a lot of meetings were spent with Dr. Clark, Dr. Tong, Dr. Ori Gottlieb, trying to figure out how we could get these patients into an operating room space, get them to an operating room in an expeditious manner. So we came up with a class system. So obviously all extenuating traumas became class A. And I never had an argument from the anesthesia service, but there were still those, because they thought that everything that they did was important, didn't understand that trauma is a little different than your flap that needs revascularization after your complex vascular procedure. So we had to fight for OR space. You can see there's a busy block. OR 17 was finally given to us as the trauma room. But then several rounds went back and forth where it was just the Class A room, not the trauma room. So you can see, okay, well, we'll give you a trauma room, but if that's filled with something else, we will make every reasonable effort to give you an operating room somewhere else. And I don't expect you to interpret these slides, but if it wasn't for the anesthesia service understanding what they needed, proximity to the blood, proximity to the OR, proximity to the front desk, I don't think we ever would have had a true trauma room versus just a rotating trauma room. So that's where I can thank them for that. This is actually one of the early slides of how we were going to ask people to interact. So we will take your room, cardiac, for instance, this percentage of time. We'll take your room, vascular surgery, this number of times. For those of you at high-powered centers, could you imagine, Peter, going to your hospital in St. Louis and telling the cardiothoracic surgeons, oh, by the way, we're going to use your room for trauma, right? So these were the difficult things we had to do in the very beginning. And oftentimes, this reminds me of the Spider-Man movie. He's trying to hold a sinking tugboat together, trying to pull everything together and just kind of stand up against the resistance of those who did not want to make the change at the University of Chicago. But, we educated everyone, and I think I got about 5 minutes left. We educated everyone. We got all the nurses, again, who had not seen trauma for many years. The hospital staff, including the surgical staff, anesthesia, ortho, we all came together. We trained, we retrained. And really, it became about team unity. It became about drilling those scenarios that I showed you, that I mentioned, the 15-year-old shot, the 18-year-old with the pelvic fracture, the pregnant woman shot. Where are we going to put the blood? And we trained, and again, and we trained some more. There's Dr. Clock at the top of the bed teaching airway issues. How do we get someone from the parking deck across the street to the CCD where they're going to get to the operating room? So here you can see on the bottom side here, there's a yellow trauma phone that rings directly from the trauma bay to the nurses there, so we can get people upstairs. These are things that did not exist before the trauma service and the anesthesia service started working together. So now you have Dr. Rogers pieces in the VRP, you have the community together, you have the training, we cut the ribbon, we're now open. So here we go. So we opened up in May 2018. For the sake of time, I'm just going to concentrate on the level 1 traumas. You can see in May, we did 105 level 1 traumas. You can see 185 and then 165 in July. The most important thing about that is, for those of you who do not have the issues with gun violence like we have here in the United States, I heard Peter mention about 20% in St. Louis. In Atlanta, it was about 20. LA County, it's about 18. Maryland's shock trauma is about 18. In the first year, we were 30. The first month, we were 35%. Second month, we were 40%. We were really trying to break this system that was brand new with the amount of gun violence. Most people talk about their number one mechanism being little ladies that fall. Our number one mechanism at the University of Chicago are gunshots. This is looking at it by years now. You can see penetrating trauma the first year, 38%, second year, 41%, and 2020, 40%, and we're about there now in the first couple of months of this year. One of the things that we've been able to do is to get people to the operating room in 15 minutes or less if you're exsanguinating, and we've never failed to do that. I'm going to kind of skip this. We've come up with innovation. This is actually an X-fix going into the abdomen because the patient is bleeding from the bone and we couldn't stop it. And this type of innovation is what we've come up with, which we have now published on. This is what it looks like. So you can see the abdomen's open. And this is basically what we have done here. And we've sent this off to IR to get the bleeding stopped. And like this conference, because of the trauma center, we've actually been able to do a conference that would have taken place if not for COVID with IR. So the trauma system has made this hospital better. We are very excited to share our innovation, our technology, our passion with everyone. The other thing that I will say is what amazes me is the attention to detail about the acute traumatic coagulopathy, the correction of bleeding that happens when they arrive. Again, this is intentional because the anesthesia service has owned that trauma room. They will, I don't want to say they will physically fight you, but they will stop you from trying to go into that room because they've set it up very well. And one of the things that we know from the military is that this one-to-one resuscitation is what is needed to save lives. And despite the numerous massive transfusion protocols that go on, we have done this very well. So I'm going to go to my last slide. I always tell my colleagues and my residents that, be careful of emails because when you send them, they go to places you may not want them to go. This is redacted, not because of anything that I'm trying to hide, but I just didn't ask for permission. But I will say this. I think this kind of summarizes where we are. This was sent in November, looking at a review of our Room 17 experience. This is from the anesthesia service. And I keep this email because it's a sense of pride for me. It captures everything that we've talked about. And it says, in response to a trauma inquiry, I manually reviewed 184 cases done in Room 17 from May 1st to November 19th. And obviously there's I'm amazed by that. For those interested, greater than 80% of trauma cases who come to Room 17 are penetrating, lots of gunshot wounds and multiple gunshot wounds. But I have to say, quietly, University of Chicago Medicine has created an awesome trauma program. I even saw 4 patients who were arrested. Sorry, my screens, I can't move my grid out because I can't read the rest of it without my grid being up. Oh, what happened? I don't know why the screen sharing stopped, but I'll say this. Everyone is impressed by what we've been able to accomplish. And again, that's from anesthesia looking at it. They've been great partners. If it wasn't for them, we would not have the success that we have now. So thank you for your attention. That was very fast, but I thought it was important to highlight where we were and how we got here. Thank you.
Ken, thank you. And don't worry, I didn't jinx you. I didn't stop your screen sharing to cut you off. That's a glitch on your side, I think.
Yeah, well, like I said, it was written, it was an internal document sent to us basically saying not only are we doing things well, but to have whole blood immediately available is something that most trauma centers do not have. And we actually even have it on our flights going out to pick up an injured patient. So we look very much like an FRST here on the south side of Chicago. And I thank you all who participated in making us this world-renowned trauma center so quickly.
Thank you, Ken. Please hang around for the panel questions later on this morning. I'd like to introduce our second speaker this morning, Professor David Lockie, who's a consultant anaesthetist and critical care physician in Bristol. He's also the chairman of the pre-hospital faculty of pre-hospital medicine at the Royal College of Surgeons in Edinburgh. So David, please take it away.
Hi, I think I'm on screen sharing now. Can you see anything? I can't. Yes, I think I'm still on University of Chicago. Does that make?
You should be able to screen share. You're authorized.
Yeah, I should be. It was working rather well a minute ago. Let me see. It says you are screen sharing. Am I screen sharing?
Perhaps minimize that and see if it's available on your desktop.
Okay. Can you see anything?
Not yet.
Well, this strange thing that's come up, which says the University of Chicago suddenly, which wasn't there before. Let me come back. And now. So, have you still got me?
Do you have 2 displays, David?
Can you see anything now?
Now
So
we've got your desktop.
You got my desktop?
Yes.
Have you? Oh, cool. Is that looking good?
Just need to launch it.
Yeah. You got that?
Perfect.
Excellent. Thank you, Jeff. Thank you for the invitation. It's very sad that I can't be there. I've been to Chicago once and I really enjoyed it. And I do hope that I can come at some point and see all the excellent things that we've just heard about. And I think there's so much for people like us to learn from what you're doing. This morning, I'm going to talk about, I suppose, a fairly personal view of the evolution of pre-hospital emergency medicine in the UK. My perspective on this is from several parts. I suppose I am a pre-hospital doctor. I've worked in London, which is an exclusively trauma service, for more than 20 years. And the last 3 years, I've also taken over as National Director in Wales of the retrieval service. And basically, we have, in addition to trauma, we have medicine and retrieval there in an urban and a semi-urban environment. And like you, I'm involved in a trauma centre. I've been the clinical director of a trauma network for many years. So I suppose the reason for commenting on that is because I not only take pre-hospital patients into trauma centres, but I also receive them. And as Jeff says, I'm just coming to the end of a term of the chairman of the Faculty of Pre-Hospital Care at the Royal College of Surgeons in Edinburgh. And that's very much, my time there's been very much involved in the development of pre-hospital emergency medicine. So the subspecialty was recognised by the United Kingdom General Medical Council subspecialty of emergency medicine anaesthesia since 2012. So we've been going for 8 or 9 years now, and there's probably around 150 to 200 doctors that have come out of the training. The things I wanted to concentrate on today were, what were the drivers for the development of this? How does the actual training work? And I suppose the most interesting part for me is, how does it actually fit into our current and future visions for pre-hospital emergency medicine? And I know that in different places and even within the same country, there are lots of views on how pre-hospital emergency medicine should be practiced. So what about the drivers for change? This is what was on the top of the development first document. Basically, the UK ambulance service should have 24-hour deployable subspecialist pre-hospital emergency medicine doctors to do the following things: provide high quality care and transfer and care during transfer, which is sort of what we'd all expect; improve the standard, the governance and the equity of care. The equity of care is something which is really quite important, because there was considerable lack of equity between different regions of the UK. Also improve medical training and leadership for pre-hospital emergency medicine, and provide good and robust medical backup for major incidents, which are seem to be occurring slightly more frequently at the moment, and are frequently in the public domain very, very quickly. There's no doubt that the development of the subspecialty was influenced by wider changes in EMS development, both in the UK and elsewhere. And I suppose this is where we started from, which is that worldwide, if you look at it from the patient perspective, there was a pretty varied response to what happens when you're multiply injured. The availability of pre-hospital critical care interventions was increasing, and I think it was sometimes difficult to know which of those we should be introducing into services. The variables tended to be around which providers attend you and what their skill set is, what interventions they can perform. The timelines, I think, quite often are thought of in terms of the difference between urban and rural, which of course there is an issue. But actually, it wasn't about that. It was about how long it takes to transfer patients from one hospital to another. And also, certainly in Europe, the timelines of different pre-hospital services are very different. And for instance, the French have never really emphasized quick scene times. If you compare, say, London and Paris, the scene times are much lower in London. How you transport patients to hospital is different in different places. And of course, what happens when you get to your receiving hospitals. I am, of course, for this talk, very aware of the divide between the US and Europe on the use of doctors in pre-hospital care. And in fact, compared to many countries, the UK was quite slow in its uptake of paid professional doctors in pre-hospital care, and many other European countries have been doing it for many years. How do we make the case to our in-hospital colleagues? Well, as I've said, most pre-hospital doctors work in hospital anyway, but there were some surgeons that don't do much emergency work that didn't really see what the point of all this is. And I think what we've done is we've tried to emphasize the chain of survival in trauma and in other things. This is the one for cardiac arrest, and made the point that really it doesn't matter how much resource you put into hospital care, the patients don't get to you alive. And of the probably many more than 14,000 trauma deaths a day in worldwide, we know that about 50% are in the first hour. If you look at the timelines of actually time from injury to arrive in hospital, as opposed to the scene times of pre-hospital teams, in most systems, most of the first hour is pre-hospital, and that's even in patients that aren't particularly trapped. As far as I can tell, the only time when scene times are really short is where the rescuers are actually under threat themselves, as we know from our military experience. And I suppose put into a simple picture, this is how we tried to sell it, that if you have an injury where the red star is there, the availability of critical interventions only really gets to the maximum when you get to not just hospital, but to the right hospital. And over that period of time which it takes you to get there, the effectiveness of those interventions can be much lessened. We all know what the things that can't wait in trauma are: airway compromise, severe hemorrhage, etc. And those are the things that we sought to address. Our job was made slightly easier because I think in hospital, among surgeons and physicians, the concept of critical care without walls, which was championed by the Australians, has made its mark, mainly in terms of outreach. But the idea that you can have a patient with exactly the same deranged physiology and pathology 50 meters away from your intensive care unit and they get a much lower standard of care is basically something which has been taken on board by most hospital practitioners. And what we've done with pre-hospital emergency medicine is just take that back a little bit and try and make people understand that basically we should be trying to deliver the interventions where they're required rather than when we can comfortably deliver them. This thing here, I know, has driven, it was good for the public imagination. It's driven the development of trauma care in some places, but this is inhibiting us now. It is unfortunately nonsense, because we know that scoop and run is really difficult to do, and actually getting a patient to hospital in 15, 20 minutes is virtually impossible in most systems. And the idea of stay and play is also nonsense, because we shouldn't be playing at all, and we shouldn't be trying to develop the concept of play. It's about doing the absolute minimum which makes a difference, and getting to the appropriate place as soon as possible. The development of trauma systems were a little bit behind you. We really only launched formal national trauma centres in 2010 in London, 2012 outside London, but this influenced our care, and you can see that the improvements in the odds of survival actually went up much faster than we thought. But this also emphasised the fact that, as you all know, trauma system development is not just about the trauma hospital. It's about the point from injury all the way through to rehabilitation. And what we found was that the middle bit, mainly the front door stuff, was being dealt with very well, but the rehabilitation tail end and the pre-arrival stuff wasn't being dealt with as well. And we now obviously seem to have accepted the fact that effective pre-hospital care is an important part of the early pathway. Along parallel to this, mainly driven by, I think, the public rather than anything medical, was that there was an increased medical presence in UK pre-hospital care. This slide's out of date, but this just gives you an idea of some of the regional air ambulances moving from double paramedic to doctor paramedic, and 2 out of the 3 of those are now there, so it's the norm now. We have a changing workload, as there is in many places. Our RTC deaths are really very low now. I think we're down to around 1,800 for a population of 60 million per year, which is a lot less than when I started. And I think we're at the bottom of the European league table with Sweden, I think. Our penetrating trauma, I'm aware that I'm talking to people in Chicago. Our penetrating trauma is going up worryingly, and we're desperately trying to learn from you in terms of how we can prevent this, this increase. I heard the numbers earlier. I think at the Royal London Hospital, which is the other place that I work, it's around 26% penetrating, but in Bristol, in my trauma centre, it's around 3%. So big differences. And also we've recognised that, of course, what we launched trauma centres for in our own minds was young RTC victims. And of course, the majority of severe trauma in the UK and in the rest of Europe is actually elderly people falling over. So we have been influenced by that. And we've also been influenced by the military, because we've been involved in conflicts before and during the development of pre-hospital emergency medicine, and the move forward of military medicine has been very useful for us. So what are the practicalities of training? I'm not going to go into this in too much detail because, to be honest, it's not that exciting unless you're fascinated by the delivery of medical education. But basically, we started in 2011-12 with some pilot trainees. We had regional-based training programs. Most of the education providers are air ambulances with involvement from ambulance services as well. And we had 6 people start in 2012. We have an intercollegiate board for training, which is interesting, and I can't really explain the way it's worked because it should really be dominated by emergency medicine and anaesthesia, but the lead college is the Royal College of Surgeons of Edinburgh, even though you can't really get subspecialty accreditation as a surgeon or as a general practitioner, which is the other one. But anyway, the idea of this is an intercollegiate board which oversees the content and assessment of training. How many do we need? We estimated that we needed around full-time equivalent, 10 full-time equivalent trained consultants per region. That will be 200 to 250 full-time equivalents for the UK. But we recognise that very few people are going to do more than probably 1 or 2 days a week, maximum 50%. So it's probably going to be twice that number, which is quite a lot for us. What do we do? Well, we undertake the training around 5 years post-qualification, at least 5 years post-qualification. We do the equivalent of 12 months full-time training, which consists of a month's initial training, 5 months of development, and 5 months of consolidation training. And you've got to remember that all of these people are relatively competent at emergency medicine or anaesthesia and have done stuff in the other specialty before they start. They have named educational and clinical supervisors, and they're supervised full-time for the first month and at least 20% after. The recruitment is national, so you apply to a national training program, and then depending on how well you do and what your preferences are, you are distributed to a regional training program. The curriculum is complex. It's mapped closely with existing emergency medicine anaesthesia curriculum. It has themes and units which have all of the underpinning knowledge, technical skills, behavioural and non-technical skills, and there are cross-cutting themes like good medical practice and operational practice. And it's a little bit military, this, in that there are so many abbreviations, it's quite scary. But the assessment techniques are many and varied and reflect those in anaesthesia and emergency medicine. There are formative assessments throughout the training year, but there are 2 national summative assessments at around 6 months and 12 months. And the first one, which gives you the diploma in immediate medical care at the Royal College of Surgeons of Edinburgh, has a high pass rate, around 90% pass that. And the fellowship, which is at the end of training, it's difficult to say exactly what the pass rate is because relatively small numbers take it each time, but it's safe to say it's not straightforward and it's not easy, and probably the highest success rate we've had is around 60%. It does also involve high fidelity simulation in addition to a large number of OSCEs and a knowledge test, and that's slightly controversial, having the high fidelity simulations. So currently we've got 12 programs approved, around 28 trainees in post. They come from emergency medicine and anaesthesia, and around 30 complete training program each year. Where does it all fit in? Basically, most people are doing around a day a week, 2 or 3 sessions, which is 1 clinical shift a week, as part of their emergency medicine or their anesthesia or intensive care job plan. Mostly they're employed in air ambulances, ambulance services, event medicine, and the military have an interest in having FEM-trained people in all 3 services. We're also trying to run in parallel, because the faculty just doesn't just represent doctors, looking at some of these diverse titles which are not really nationally recognized in terms of paramedics with advanced skills and how they can fit into this type of training program. But we believe that the doctor's CCP team model is working well in delivering the type of pre-hospital emergency medicine that is common in the UK. How does it fit into current and future pre-hospital care? This is slightly my view of things. So in terms of changing the pathways, I think we're influenced by system changes like the trauma networks, providers, things like the availability of doctors and advanced paramedics, and transport. But really, the advances are coming from 2 places. They're coming in parallel with in-hospital medical development. So in other words, if something looks good in hospital, we work out whether we can use it in pre-hospital, whether it confers any benefit, and do that. And then also there's non-medical technology, and I'll come to that back to that in a second. The implementation of technology from outside medicine into pre-hospital care. So what are we trying to do when we modify our existing pathways? Well, mostly delay or prevent deterioration or death until we can get them to hospital, and treat time-critical pathologies that can't wait. And there are other things, of course, like adequate analgesia. So from in-hospital care, this is the type of thing that's happening with medical cardiac arrest in the UK. You have your out-of-hospital cardiac arrest. If you're lucky, you get a rapid response by standard CPR. You have ALS. And if you don't get ROSC, you stop and you die. If you do get ROSC, you get to the emergency department and you get interventions like PCI if you're lucky. The sort of things that we've done is that in selected patients, if we're not getting ROSC, but we feel we should have done, and the timelines are right, we go straight to the cath lab for PCI. And we've had some very good results from that type of thing. And you'll know that in France and several other centres, you can actually bring ECMO to the scene if you think it's a good idea. And the problems with that seem to be very much around the timelines of low flow. If you put people on anything really after 40 minutes, it doesn't really make much difference. But if you can get there really early, it might. What about traumatic cardiac arrest? Well, most of our penetrating trauma is knives rather than guns. So we do have pathways like this. You have a cardiac arrest on scene from penetrating knife trauma, transported to the emergency department. If you're lucky, you survive and go to theatre for thoracotomy. But the mortality, if you've had a cardiac arrest on scene, was 100%. So that's when the modification of on-scene thoracotomy, a bit controversial, came up. And I think the bottom line with it is that if you have a significant number of these in your community and you can train up properly and you're there at the right time, it's the right injury, you can get very good survivors. And the important thing in our groups of survivors is that the good neurological outcomes make up the vast majority of survivors, which is good. In terms of things like pre-hospital anesthesia, this was a study we did some time ago. Patients that need it, actually a very small proportion of the total. But what we tried to identify here was that when we arrived at a scene, mostly patients had been seen by paramedics and had paramedic level. I mean, these are the worst injured patients, but they had paramedic level airway management before we got there. And what was interesting is that the 472 patients, when they had those interventions, 200 had no airway compromise by the time the enhanced care team arrived, but actually 63% still had significant airway compromise, which we use as a bit of a justification for what we do. We have guidelines for pre-hospital anesthesia, which have been taken up by pretty much all the services. And basically, they're very straightforward. They say if you're going to do it, you need to do it to the same level as in the emergency department in hospital. And if you can't do that, then stick to basic airway management. And basically, difficult pre-hospital conditions are not an excuse for low standards. As a result of that, we've done pretty well. We've basically got better intubation success rates than in our emergency departments, better data collection, no unrecognized esophageal intubation, and 100% success in our intubation failure plans. And that was, we published that back in 2014. It's been repeated by other UK and other services. We've even gone a little step further and been slightly provocative and suggested that the way that we do it in a structured, low choice way may have some lessons for in-hospital management. And a lot of our pre-hospital doctors who are in the emergency department recognize the fact that the way they were trained pre-hospital, if they take those things back, it means that their in-hospital emergency management is much improved. Went down well in some areas, not in others. What else have we managed to do? Well, the safe introduction of pre-hospital blood, and we've used whole blood in London for a while, I think for 2 years. And we managed to do it when we look at the metrics of safety, like traceability and all of that sort of stuff. We're actually doing it better than in the hospital, which is interesting. Things like more advanced things like Reboa, we have managed to do this. I was just asking my son, who's 16, when his 7th birthday was, because this was the day that I was on call when we did the first one in London, some 8 or 9 years ago. And we've done a number since then. I think it's important to realise that London has more trauma than most places in the UK and most places in Europe. And in fact, it doesn't really, not many patients meet the criteria. So it is a difficult and high intensity thing to put in place, but we've had some great success stories. Obviously, if we can give drugs to people pre-hospital and the timelines are good, that's good. We use PCC for the reversal of anticoagulants, well, warfarin, obviously TXA, and then we're looking at other things which may have benefits. So what about the application of non-medical technology to pre-hospital care? I think when we talk at research meetings about trauma research and how many lives we saved, I think we have to recognise the fact that when we look at road traffic accidents and improved survival, it's not really about us at all, of course. It's about safer cars and it's non-medical technology. And there's much more of it coming. It's not quite up to the level that we'd like yet, but things like automatic crash notification is developing. We know that there are some issues, but things are only going to proliferate into our practice in the next few years. One of my friends and colleagues, a neurosurgeon, set up this, which is one of several available apps which connect up people who need resuscitating with people who can do CPR and people who can get public defibrillators. Works incredibly well. And you can see the type of thing you get there down on the left, which is the amount of people that are available in a particular area. And this is particularly useful in rural areas, but basically provides the important things before the ambulance service get there. Drones, I think, are an interesting thing because, of course, flying in helicopters, we think they're a bit of a hazard, but actually they're cheap, they're easy to fly, they can work in non-permissive environments, and in terms of major incidents, they're pretty much disposable. Here's a document from a long time ago. I'm not sure whether the abbreviation ISIS is great in that if you had a major incident, I'm not sure if you'd be reassured by the fact that ISIS were overhead helping, but we've developed a lot since then. And you'll be aware that there are a number of innovations. These are Lifesaver Drones, which basically are used in a number of countries to develop to respond in patients who may or may not be in trouble. So they fly this drone out there. It can see whether people do actually need a response, and then it drops these things onto them, and it works pretty well. And also, if you've got 6 or 7 people that need rescuing, it can actually buy you time while you get people out there. There is a little bit of a beach trial here, which you can see. And I don't think, I mean, this is only a minor thing, but I think it just illustrates how we're moving. This is man versus machine. And as you can see, the man hasn't got a chance. Some of my swimming friends have commented that perhaps if he wasn't doing butterfly, he might have got there a bit quicker, but who am I to say? So we've got similar things that happen for cardiac arrest, where you can take a camera and a defibrillator to the scene, get there quicker, and then you can instruct people as to how to use them. And I gather this is 12 kilometers in a minute or so, which is quite quick. And these are being developed in various countries. I think this one's from the Netherlands. And then a US company have produced this stuff in Rwanda, where it's incredibly difficult to get around at certain times of the year, and basically have this wind up machine, which then comes into life and can develop and can deliver things to people's mobile phones, because despite the fact that the roads are bad, everyone has a mobile phone. And I think this type of innovation is really impressive. So the answer to the question, what can we do on scene, is most things. If we want to put the resource into it and the training, we can do anything. We could do laparotomies by the roadside. We can do whatever we want. This is the stroke thrombolysis ambulance with a CT scanner in Germany. Someone doing ultrasound in space. I'm not entirely sure what you do when you've got a positive result there, but I don't know. But the answer really is not what can we do, it's what should we do? What is it that's going to make a difference to our patients? And that is much more controversial. I don't think there's any doubt that there's some very ambitious zero mortality visions. We've certainly got one in our city in Bristol, where we're aiming for zero mortality from cycling accidents. You'll know that Volvo have got a zero mortality vision for people dying in Volvos. In other words, none by, I think it's 2024 or 2025, helped somewhat by the type of people that drive Volvos possibly. But anyway, what I'm trying to say is that if you have a zero mortality vision, it means that you have to get those details, and it may involve these higher level interventions. The interventions must, of course, be tailored to the timelines and operating conditions of the specific EMS, and trying to do Reboa in Norway or something isn't really going to work. I also work in the Falkland Islands, and we have state-of-the-art 2 very expensive helicopters, but unfortunately at the other end we take them to a fairly basic hospital. And I think it's really important to look at the whole pathway. I've nearly finished now, but working in an evidence-poor environment, what's the motivation? We've heard from the last speaker that it's individual patient stories. It's patients that shouldn't have survived that do survive. And I just thought I'd share with you for the last 2 minutes a story that I run the London Trauma Conference in London. And a few years ago, we had a guy called Steen Barnum who was talking about an incident in Denmark. And I think one of the things that I look at when I hear stories like this is, how would my system do? And I have to say, when I heard this story, I thought, not very well. But anyway, see what you think. Basically, this is a group of 14 or so teenagers, or 13 students and 2 teachers, that went out with water temperatures of 2 degrees and capsized their boat. It's quite a long way from the nearest teaching hospital, 88 kilometers from, I think it was in Copenhagen. And the first doctor appeared quite some time after the incident, around 90 minutes or so, and found 7 asystolic teenagers and a lot of others that were very cold. And this is where it gets interesting. He apparently, the phone call, I mean, Scandinavians aren't very excitable, but he rang the hospital in Copenhagen and said, I'm bringing you, after a boating accident, I'm bringing you 6 or 7 youths who need ECMO. They're all very cold and they're all asystolic and have been for some time. And apparently the answer to that was, right, well, okay, I better not spend much time on the phone. I better go and get some kit sorted. And they did. They sorted out 6 sets, and they got another one flown in. And here you can see people still doing CPR several hours later. And the times here are quite interesting. Time from accident to first EMS contact, 121 minutes. And basically time to ECMO start, hours. And, the details are fascinating, but probably not for today. But I don't know why this is the results. They all survived. And one of them had some minor disability, but all of these kids are now at university and doing pretty well. And that was the sort of story, I think, made me think that you need a few of those every year just to make you realize how your system could work better. Because if I rang up and said I need to put 6 people on ECMO, I know what the answer would be. So in summary, I think subspecialty pre-hospital emergency medicine is one way to ensure that your providers of pre-hospital critical care are properly trained and competent. Certainly, it's very popular, competitive, and it delivers trained providers to fill the posts that are currently available. It complements, doesn't compete with advanced paramedic training. And it allows the delivery of the existing advanced critical care interventions. And should you wish to put new ones in, it gives us a platform for delivering those. Thank you very much for listening. It's very difficult talking to yourself, but I hope you're all still there.
David, thank you very much. If you could end screen sharing, I will open it to our next speaker. That's Professor Richard Dutton. He's a former anesthesiologist at both the University of Chicago and Shock Trauma in Baltimore, and he's currently the Chief Quality Officer for US Anesthesia Partners, and obviously section editor for trauma within the Anesthesia and Analgesia Journal. So, Richard, over to you, sir.
Thank you. Do you have my screen?
We do.
Excellent. Off we go. I'll be quick. So you know you're a dinosaur when people start inviting you to talk about myths in your specialty. I have been a traumatologist and an anesthesiologist for something like 30 years now. I have no financial disclosure relative to this talk, and I'm going to go very fast. I know I'm talking to a bunch of experts, so my goal is to be provocative, maybe not conclusive, but my email's on the last slide. Feel free to contact me if you have questions, want references, etc. So I have done trauma care in a number of environments. I'm a veteran of the US Navy. I spent 17 years in the big white box of chaos in Baltimore. I'll talk a little about that as we go. I left that job in around 2009 to go work for our society, the ASA, as their chief quality officer. And I kept my hand in by working clinically at the University of Chicago. So same building, different view here. Ironically, during the period when it was not a trauma center. The first day I showed up to talk to Dr. Affelbaum, Peter's predecessor as chair, about working there. There were protests going on in the community. I think Dr. Wilson referenced them. But the 5 years I was there off and on, there was no adult trauma. And it was a tragedy, as Dr. Wilson described. Today, I am Chief Quality Officer for the largest anesthesia group in the US, about 4,000 clinicians right now. And I work clinically at Baylor University Medical Center in Dallas, a level 1 trauma center. So I do get to do trauma again and enjoy it very much. Here are the myths. I'm not going to linger on this slide because I'm going to talk about them. So first one, this connects with what you heard from Dr. Wilson and Dr. Lockey and has to do with systems, right? You've heard this statement, speed wins. I agree, the stay and play versus scoop and run argument is overly simplistic in both directions. Obviously, you want to do everything you can while moving the patient as quickly as possible to definitive care. I had the pleasure of working for a long time in Maryland, where I was chief of anesthesia at the trauma center there for quite a while. I was also the medical director of our resuscitation unit and ORs, which interestingly are essentially one large suite in the at shock trauma. And I should say, Dr. Wilson nailed it, 18% penetrating trauma in Baltimore, a mere 1,000 gunshot wounds a year there, because we are a very large volume center. The catchment was about 6 million people, the entire state of Maryland and surrounding states. You can see how the system is put together. Pre-hospital time in our population as a whole was between 20 and 30 minutes. This is the epitome of American scoop and run trauma care. And I have to say, Dr. Cowley is credited for creating the first freestanding trauma center in the United States, our own building, our own 8 ORs, 13 resuscitation bays, ICUs, pharmacy, blood bank, et cetera. But what he really built that made it work was the system statewide, the support of the state, the pre-hospital community, the helicopters to get people here quickly. And oftentimes it wasn't clear which building you'd stopped in. We did have pink scrubs, that's another story. But Probably the most interesting thing about the trauma system in Maryland is that it really does function as a system. And at Shock Trauma, all of the doctors there were traumatologists first, and whatever specialty they were second. So an anesthesiologist met every patient who arrived there. We were there along with the emergency medicine doctors in training, the surgeons. There is always an orthopedic surgeon in the building, always a senior neurosurgical resident, or most times an attending. And everyone who worked in this building took care of trauma patients as pretty much their first and only job. So a huge amount of concentrated expertise. And it is the team that really achieves the results. Lots of protocols. I won't get deeply into this. You'll hear more about this through the rest of the day. But does it work? Well, yes. As I was leaving there, I've been the quality director for many years. I had the entire trauma registry at my disposal. And this was the last paper I wrote as I left Shock Trauma. What did we do over the time I was there, pretty much? And what you see is interesting in a number of respects. So we got up to over 6,000 admissions a year. And you can see, discouragingly, when I first looked at this, the death rate remained a fairly constant, somewhere between 3% and 5% a year of patients who died before discharge from our center. Now, we counted everybody who rolled through our doors in admission, so many of them were dead on arrival, particularly with very short transport times in downtown Baltimore. But the most interesting feature of this was the risk-adjusted mortality, and that's what the black triangles represent here. And that 7 over on the right, the Z-score of 7, shows that our outcomes compared to the National Trauma Registry were 7 standard deviations better. And obviously statistically significant. You can go on and calculate what's called a W score from this. So we knew that for every 100 admissions we had, we saved about 1 excess life for that. This is the largest experience ever reported in the trauma business and still among the best performance. I'm very pleased with this. And it was the result of having an integrated system. Here are some of the components of that. Again, I won't go deeply into them. A lot of it is codified by the College of Surgeons Committee on Trauma in the resources book. I'm pleased to say in the most current edition, anesthesia's had a greater role in participating in writing the requirements for resources. All right, second myth, we'll jump into the science, and this is for the anesthesiologists and ED docs and possibly some of our pre-hospital folks out there. The longer I worked it, the less I cared about what drugs we used, to be perfectly honest. So the Friday night rapid sequence intubation of a trauma patient, which we probably did 8 or 10 of every week, and have written about extensively. It turns out, in my experience, it really doesn't matter what agent we used. For many years, we used pentothal. Eventually, we couldn't get that in the US anymore, and we switched to propofol because it was cheap and readily available. But it turned out that what was much more important than the drug was the dose and the experience of the person administering it. And what I used to teach my residents is that for a trauma rapid sequence induction, the dose of propofol was 0 to 2 milligrams per kilogram. And if the blood pressure is 70 over 55, in a patient with penetrating trauma, I would rest the propofol syringe on the patient's chest, push the sucks, and we'd get on with it. And that was as close as it would get to their circulation. Trauma patients come in with very high catechol level, and any agent, even quote safe ones like ketamine or etomidate, are going to remove the patient's own catechol drive, and you will have precipitous hypotension if you give them too much. Very nicely documented in a whole series of very elegant animal studies from the University of Utah, if any of you are interested in this, showing that in hemorrhagic shock, the amount of any sedative agent you need to turn off the brain is very small. All right, I'll linger a little more on this third point. When I entered the business in the early 90s working for the Navy, we all knew what to do with hemorrhaging patients. You just gave them all the volume you could as quick as you could. And that was the big myth of the day. Walking through history, in 1970 in the United States, you bled to death at the scene. By 1980, through the efforts of Dr. Cowley and others, you could get transported to a trauma center to bleed to death. By 1990, we finally started to get good equipment for getting fluids into patients rapidly, so better lines and line kits, rapid infusion systems and the like. You could make it to the OR, getting a lot of volume and bleed to death. Here's a typical shock trauma picture from that era with lots of equipment for managing the patient in hemorrhagic shock. But I rapidly learned, and some of the first academic work I did was demonstrating that you had to be smarter than the rapid infuser. In other words, we had to use it well and not just use it. And it turned out the most important piece of equipment in the room was the one standing in the middle, the Texas issued trauma surgeon. That's Dr. Phil Militello there, who could stop the patient from hemorrhaging. We figured this out. The Maddox paper was published basically as I started my career at shock trauma. We repeated a variation of that study there in my first years there, and got to figure out how to break ourselves out of this vicious cycle. So by 2000, we had damage control, both surgery and starting to think about damage control anesthesia. We had discovered the concept of delivered hypotension. I won't get into this, you'll hear more about this today. But the problem is that delivered hypotension, while effective in some patients at keeping the blood in the body, so it did work and we did demonstrate benefits with it, it was counter to what we knew about the physiology, right? We were perpetuating the patient's state of shock by giving them less fluid and by not restoring perfusion. So we were robbing Peter to pay Paul, basically. And well, in some patients, it was right to stop the bleeding faster. In others, we were probably hurting them by leaving them in shock for longer. So this led to more thinking. One-to-one resuscitation. I'm pleased to have had a big role in getting that into practice, at least in a pragmatic way. We switched around year 2000, we switched our resuscitation to basically 100% blood based. We stopped giving crystalloid. We went to one-to-one-to-one. And our rule was if you were in shock, the fluids you got had to either clot or carry oxygen. By 2010, we had well-advanced massive transfusion protocols. We wrote a paper in the 2000s showing that these essentially didn't exist in the United States. But I'm pleased to say that now every level 1 trauma center and pretty much every large hospital has a massive transfusion protocol. And breaking down those logistic barriers, just getting blood products to the bedside turned out to be one of the most important things we could do, because that then empowered the clinician to do the right thing, figure out which products were needed in which patient at which time. Tranexamic acid came on the scene. Here's one of the slides that got one-to-one-to-one off the ground. As we pointed out that giving component therapy, what you were actually giving to the patient was sort of marginally compatible with life. And this is with no crystalloid dilution whatsoever. By the time you take a unit of whole blood, fractionate it, spin it a bunch, run it through a bunch of centrifuges and tubing, what you're actually giving back to the patient in those components when you mix it back together is only kind of so-so. And this is one of the things that prompted us to stop giving crystalloid. Right, there's our principle. And we began pushing hard on this. This meant giving a lot of uncross-matched blood. And we wrote a paper about this. This is, I think, our experience from year 2000. 550 to 600 units of uncross-matched type O blood a year. You can see the mortality in the patients who get it is high. This is a great marker for patients who are dying in the resuscitation unit. And we looked at the serology of this, no evidence of immune reaction, and even patients converting from Rh negative to Rh positive when we gave them O positive blood was quite rare. Right, massive transfusion protocols, I mentioned this, access to type O blood, and now I would extend that to say not just type O, but plasma and platelets, and today, whole blood, absolutely. The fact that they're doing this now in Chicago is tremendous, shows very rapid progress. We're doing this in many cities around the US now, and even pushing it into the pre-hospital community in places like Baltimore, Pittsburgh, and Houston. This is absolutely the thing. If you look at resuscitation with whole blood, there's a bunch of military experience around this. It really is incrementally better than component therapy. We looked, there was a lot of controversy about ratios of red cells to plasma and a huge amount of debate about this. This was the shock trauma take on it. circa 2011. We looked at plasma deficits. We were aiming for 1-to-1. And if you had gotten 3 units of red cells and 1 unit of plasma, you had a deficit of 2. And that's how we were calculating this. And we looked at high, middle, low deficits. And consistent with other research, patients with low plasma deficits, closer to 1-to-1, did better. But the other interesting feature of this study was that it was all over in the first 2 hours. So again, speed wins. If you lived past 2 hours in our trauma center, it essentially didn't matter what your resuscitation was, you were probably going to survive. Right, early resuscitation. And here we are in 2010. Today, we can crank this up to 2020 with more significant advances in the trauma business. Other folks will talk about some of these things today. Roboa, absolutely. I've used it a couple times at Dallas now, both in trauma and in OB patients, unexpected accretas. It works great. And compared to open chest aortic cross clamping, huge improvement. I think any major trauma center should have this in the repertoire and should use it when needed. Viscoelastic testing, other things, whole blood I mentioned. I think we're actually ahead of my timeline on this today in that we're getting there. Now, I'm not going to talk in detail about it. Here's another myth. The bleeding is a localized problem. There's no question that bleeding is a problem and you have to stop it. And the quicker you can keep the blood from leaving the body, the better the patient's going to do. And that's why surgeons are so important. But also all of the elements of the Stop the Bleed campaign. So tourniquets, pressure, local control. But what I got interested in is some of the consequences of bleeding. It is a systemic disease. This was a cover from the Journal of Trauma as we worked out the concept of the acute coagulopathy of traumatic shock. And what was unique about this and why I was on the cover in 2008 was the idea that it wasn't just the bloody vicious cycle of dilution and hypothermia and acidosis and a sort of mechanical effect that was making the patient coagulopathic, but there was actually an immune response going on in here as well. And that's what your coagulopathy of trauma really boils down to. The fact that if you make endothelial cells ischemic, they react badly. And what you rapidly get is a systemic disease. This is a cartoon of that. So ischemia triggers cells. They release hundreds, maybe thousands of different mediators. Some of those we're starting to understand, many we still don't. They reduce toxins like lactate and free radicals. This leads to cell damage outside of the area of trauma, particularly the lungs, the liver. This obviously triggers your multiple organ failure effects in the lungs and kidneys, which then leads to this cyclical phenomena. More cytotoxins are released. And there is something about this immune response that's very bad for the body. Obviously, different patients have very different genetics, come at this in different ways, and we get a lot of varied response out of this cascade. Understanding this is really going to be the next generation of knowledge in trauma care. How to wade into this, right? Because some inflammation is adaptive, right? You need it for healing, you need it to recover, but too much is bad. And managing the patient through that roller coaster of inflammation and keeping them in the midline of ideal inflammatory response is what we really need to be able to do. And that's going to require two things in future trauma research: measurement, so we know what the patient's inflammatory status is right this second, and then mitigation, so we keep them in the optimal point of inflammation for recovery. For all those of you starting your careers in trauma care, I'm pleased to say there is lots of science yet to go. A spin-off of the last myth is this notion that we understand coagulation. As a major proponent in the US of one-to-one resuscitation, I would go to European trauma meetings and get absolutely hammered as an empiricist and an idiot, right? That's such a dumb approach. Obviously, no patient needs exactly one-to-one-to-one. We should be smarter than that. And we got into it because we started to understand that coagulopathy was very important, right? This is early data. This is 35,000 trauma patients up to about, I don't know, 2005, I think, when we wrote this. And it shows that in the ISS higher than 25 group, the severely injured group, if you looked at the patient's INR on admission, you produce this wonderful stair-step graph of their mortality. The more coagulopathic you were as you rolled in the door, the more you died. And this is because coagulation as a marker captured the two things you die from in trauma, which are acute hemorrhage and brain injury. And both of those caused an early change in the INR. So this, it turns out, this is your best marker of mortality at trauma admission is the PT time, believe it or not. And that's what got us focused on coagulopathy. That's what got us into one-to-one. Other people wandered into this from other directions. Obviously, CRASH 2, highly provocative, huge impact on survival of giving tranexamic acid early, but no difference in transfusions. So maybe it wasn't the bleeding. Maybe this is an inflammatory mediator. We all got something like this in medical school. We learned it for 10 minutes, took our boards, forgot it instantly, and just as well because this is, a tiny part of what's really going on. As I said, hundreds to thousands of mediators going on here. In recent years, we've gotten a lot better at understanding what's happening inside the red cell, inside the platelet, and inside that endothelial cell that doesn't even fit on a picture like this. Stealing from Karim Brohi, an old friend, also at the Royal London for many years now. Our coagulation system is supposed to look like this. It's supposed to be a symphony playing beautiful music, but when you make it ischemic and damage some tissue, you get a sound effect like this, a cacophony. Everything gets disordered, and not only do you have wrong levels of all of those hundreds of markers and mediators, but they're no longer interacting right. So you get secondary interactions that are failing as well. I think it's going to be a long time before we completely understand this. It would be great if we could get to precision resuscitation, do a very rapid TEG or ROTEM on the patient, know exactly what clotting factors to give them. But I'm still giving whole blood and FFP because I think there's lots of stuff in there that we can't measure and don't know yet. Right? We got to the concept of hemostatic resuscitation, where we are now. So early emphasis on fixing coagulation. And then I'm going to wrap up here to keep us more or less on time with a essentially completely unexplored literature area in our literature, and one that I hope somebody at this meeting, somebody will pick up and run with. I haven't figured out how to do the science here, but there ought to be a way. And this is the idea that when I walked into the trauma business 25, 30 years ago, it was not unusual for a patient in hemorrhagic shock coming to the OR to get medicated with scopolamine so they wouldn't remember us, and vecuronium so they wouldn't move and the surgeon could work, and no other anesthetic, because it would make them hypotensive and make their management more difficult. It turns out, though, that being anesthetized probably greatly improves your outcomes from trauma. We can look at the same blood loss in the same kinds of patients in elective surgery versus trauma. And the trauma patient who starts out unanesthetized, vasoconstricted, does vastly worse than a patient who is already anesthetized and then bleeds. And I'm talking like 2 orders of magnitude difference in outcomes for blood loss. Obviously, anesthesia is humane. We want to lower catechol levels. We would like to perfuse the patient at the same time as we resuscitate them, and that's the real trick. So I've had this theory now for probably 10 or 15 years that the quicker we could get the patient deeply anesthetized, the better we would do. Obviously, you have to titrate this very carefully. The way I typically do it is with fentanyl, because I'm a dinosaur, and it's easy and it's cheap. And I will take my trauma patient early in resuscitation and I will give them half a cc of fentanyl, and their blood pressure will plummet. And then I will give them some volume to fill up the space I just created by vasodilating them a little bit. And their pressure will come up. And then I will give them a little more fentanyl and fluid and fentanyl and fluid, and back and forth, titrating both up until I get the patient anesthetized with a filled up vascular volume with blood products, as I said, and that really improves their survival. Anecdotally, This sign, I don't know if any of you Chicago folks have seen this. It's on the north side, just at the border of Park Ridge. The Resurrection refers to the Resurrection Hospital there, but I always thought this was our goal, and we really all needed this signpost. So with that, I'm going to stop. I hope I've been provocative. Please, the younger folks on at this meeting, go study some of these things. Let's keep getting smarter. Thank you all very much for your time and attention. And thank you, Dr. Tong, for the opportunity.
Rick, thank you. Wonderful as usual. So now we're at the end and actually on time. So thank you all, three of you, for keeping to time. I'm going to invite the three Alpha Session panelists to our Q&A session. I've been taking some notes, so rather than asking the audience to ask the question, I'll do it. So the first one is to Ken. So how do you clinically assess blood loss in a polytrauma patient?
I don't know. No, I mean, it's, you know, one of the things that is interesting is that, you know, I saw Dr. Dutton pull up, you know, one of the manuals that we look at. And of course, one of the manuals that we look at is ATLS. And we do airway, breathing, and circulation. And I do circulation first, just kind of like the military. And so the way that I assess it is really from the basic level is if I put your hand on your carotid and you have a pulse, it's 60. If I put it on your femoral and you don't have a pulse, and if you have a pulse in your femoral, it's 100. So somewhere between your groin and your neck is the first way that I do it. I don't really waste time trying to figure out in that acute setting how much blood you've lost. Because sometimes it's impossible, especially in Chicago where you get shot in multiple cavities. So that's how I assess it, is the circulation if you're not perfusing. And then and I appreciate Dr. Dutton taking it a step further. Then we start the resuscitation with the match 1-to-1 to 1. So I don't want to get into the old algorithmic look of if you've lost 25%, 50%, if your urine output's down, if your blood pressure drops. Sometimes those are just misleading. As you know, even with young kids, they can have a great blood pressure, then crash on you, and it does not mean that they were ever stable. So carotid pulse, femoral pulse, and start the resuscitation in a balanced manner immediately.
Thank you, Ken.
I'm actually a big believer in the 1-second test, Jeff. I look at the patient. We are all very good at identifying people in shock. They don't look the same.
Right.
You know, it's 1,000 subtle clues. They're a little pale, they're a little sweaty, they got their knees bent. You know, the classic trauma nurse statement, wow, his feet don't look right. Right. And we've all heard that, and go with that. You know, if your gut is telling you this person doesn't look right, that's when I put the Sudoku down, stand up and get engaged.
Well said.
David, question for you. Could you explain how pre-hospital care physicians are paid for their time and services?
Yeah, it varies between different services. In the two services in London and Wales that I work for, basically we get a budget, and we pay the hospitals that employ the doctors, and it's integrated into part of their total job plan. That's probably the most commonest way of doing it.
Okay, and what about medical litigation and medical insurance?
So every single air ambulance is associated in some way with an NHS body, a health service body, and they provide the governance and medical and legal support for that service.
Thank you. The next question may cause some
controversy. Not really a big problem. I don't think we very rarely hear of doctors that have litigation against them from pre-hospital work.
Yeah, thank you.
Jeff, can I ask David, how do you guys justify the cost of physician being in the pre-hospital care compared to paramedics in NHS?
It's pretty straightforward, really. I think if you look at it on a patient-by-patient basis, you could argue that the costs were fairly high. Actually, if you look at my service in Wales, we're providing a national service for probably £7 million a year, which has got 24-hour doctor service. If you compare that to the budget of an emergency department, it's very little, really. So I think it's all relative.
Okay. I said this next question may cause a bit of controversy. We've got surgeons and anesthesiologists, pre-hospital care providers present. So it's, how would you, do you consider intracardiac epinephrine following pre-hospital cardiac arrest and thoracotomy an option?
I suppose it's an option. It's not something I've ever done or seen done in my service. I think you'll know that there's a lot of controversy about the role of adrenaline, and I think basically most of our pre-hospital thoracotomy survivors have some cardiac activity when you open them. So once you relieve the tamponade, there's basically a little bit of activity. So the most important thing is doing some cardiac massage to get the heart size down to normal, and then hopefully it restarts spontaneously. We then sometimes have an adrenaline requirement, which is given intravenously, possibly with possible use of an infusion. But no, I think sometimes at the end of it, if it's not working very well, we're giving boluses of adrenaline, but not really, no.
Yeah, one of the rules of trauma is that every patient responds to epinephrine once.
Yes.
So I know exactly where this is coming from, since it's my good friend who's in the building with me, and we have a lot of ED thoracotomies, and I'm going to talk about an American football example, Jeff, is, have you ever seen a 60-yard pass into the end zone as a Hail Mary work? And every now and then it does. So that's kind of where we are when we're doing that. We consider the physiology, we consider that, ED thoracotomy, perhaps we can get them upstairs, and just like that Hail Mary to the end zone, it seldomly works. It's exceedingly rare to have even the person have a good neurologic outcome. So I think I would not put it in the algorithm as something you should try often, but every now and then it's what you're left with, get that adrenaline rush back.
The difference also is, Ken, that you're dealing with people that are different to us. We're looking for a single pathology. We're looking for patients who have arrested from tamponade, and relieving the tamponade is the critical thing. And then, the inotropes and stuff are pretty secondary to that. Whereas you actually, because you know what you're doing, you're moving into much more complex pathology than we try, and we try and avoid that pathology.
I would second that. Looking in 20 years, looking at hundreds of ED thoracotomies, I did pull our data at some point to write it up. Truly, the only survivors of ED thoracotomy were ones in tamponade. Yeah. And when you got in there, found a tamponade and relieved it, you had a shot at fixing whatever was wrong. But those who exsanguinated and arrested, almost zero survival.
Thank you. Rick, you mentioned factor 7 in your presentation. What do you feel is the current role for factor 7 in care?
So probably in 2010, when I left shock trauma, I'd given more doses of factor 7 than any doctor on the planet, because we used it a fair amount and we did a lot of research with it at the time. I'm pleased to say it's used very rarely now, and that's how I think it should be. I think if you do everything else right, you rarely need it. And the biggest impact of factor 7 on our science was in convincing anesthesiologists and surgeons that we actually could affect the coagulation system. Hey, wait, there's something we can do about it. And once we knew that, then we found better ways to do it. So obviously, if you're resuscitating with whole blood or 1:1:1, the chance that you need factor 7 becomes much lower. And we observed that. And as we've gotten better at understanding all of the risks and benefits, TXA earlier, better hemorrhage control through things like REBOA and damage control surgery, tourniquets, and et cetera, we have managed to avoid the situation often enough. Today, I would use factor 7 in 1 or maybe 2 situations. This line of research has never been fully completed, but small doses of factor 7 in patients with traumatic brain injury, I think there is still some potential there, particularly if it facilitates rapid intervention. So getting a patient with, for instance, a subdural to the OR quickly with a small dose of factor 7, that we found very helpful. And that, I think, is one role. And the other is in the completely out of the box, massively coagulopathic multi-trauma patients. The one who's gotten 50 units of blood products, all of the anatomic bleeding is controlled, and they're still oozing everywhere. And the, call it the hot shot of the crazy glue concept, factor 7 platelets and fibrinogen, all delivered at the same time as a cocktail, you can sometimes get that patient to stop bleeding. And if you fix the anatomy, they will stay stopped. And I have a few great saves in that setting, what Dr. Wilson referred to as the Hail Mary. So those are the two situations right now where I see it being useful.
Thank you, Rick. One question. I think we all appreciate the value of a one-to-one approach in product resuscitation. So this is to all the panel. Do you prefer this approach, which has been described by Albert as the kitchen sink approach, or do you prefer a more of a concierge approach where product and drug therapy is based on viscoelastic testing? That's the panel. Anyone?
Yes. So that's the debate I've been having with my European colleagues for years, right? The Austrians want me to do ROTEM early and then give specific factor therapy based on the results rather than this shotgun approach. And they are partly right and partly wrong. They are partly right. And obviously, if I load up the shotgun and shoot it at the patient, they're getting a lot of things they don't need. And some of those are probably bad, right? We know that the more plasma you get, the higher your risk of ARDS, for example, afterwards. So clearly, there's some evil humors in there as well. But there's also things that God put in there that we still don't understand entirely and can't measure. And so my take on it today, the broader take is if you are confused, one-to-one is easy to remember and very simple. So if you don't know how much blood the patient needs or how long they're going to be bleeding for, one-to-one, or whole blood, even better today. Once the dust starts to settle, obviously we should look at TEG and ROTEM. We should look at all our labs and we should become much more precise about giving the things the patient needs, whether that's specifically platelets, specifically clotting factors, TXA, if they're overly fibrinolytic, calcium, et cetera. So resuscitation should move from dumb to smart within the same patient as well as time and knowledge allows.
When I look over the drape in our hospital, I see the picture very similar to what Dr. Dutton showed, is about 5 people moving back and forth, working very quickly, very fast, very hard, big dumps of blood. I'm thinking, unless you have someone who is dedicated to draw the blood gas and do that ROTEM study, when are you going to stop and do that? So until you get caught up, I think the best way is, I just mentioned again, I should probably have worked at shock trauma. We seem to get along very well in our opinions, is you got to do the one-to-one. It's just too intense. It's too fast, too much going on both sides of the drape to actually ask for a concierge in the middle of a resuscitation.
I just want to interject here, just to share with you what we used to do in the military. There would be technicians whose sole role was to analyze and put the specimen into the ROTEM machine so that you could subsequently determine and decide what would be the best product and the most appropriate product to give. So it was a dedicated role to additional staff, which in a military setting, you frequently have additional staff.
Ask your boss for more funding to get that guy.
So
right the tick.
We've probably got time for one more question before we start Bravo session, and it's from Dr. Katcher. Basically, again, I think this is probably the best directed at Rick. Early immune modulation in trauma patients along with TXA. What do you think about this as approach to potentially change disordered coagulation?
Yes, not today. Today, we're doing a lot of immune modulation in a dumb way, right? All that plasma, all those blood products, all that, and any blood that wasn't yours is a transplant. And that's a lot of immune modulation happening very quickly. TXA, as I mentioned, probably is doing something in that realm as well. Our anesthetic agents, I mentioned, both directly and indirectly by lowering catechol levels, are probably immune modulators. There's a lot going on there, and in the future, we will get much smarter. The ability to genotype the patient as they roll in the door, it will first be applied in the ICU in the subacute phase, this is a patient with that coagulopathic phenotype versus the thrombotic phenotype. I think we're seeing some of this with COVID management as well, is the ability to quickly sort out who's in which group, who benefits from blood thinners, who benefits from procoagulant agents, and who might need very specific immune therapy. It's all coming. Like I say, lots and lots of research to go.
Thank you, Rick, David, Ken. Thank you all very much for your contributions and expert presentations. I would now like to give us no, we've got 1 minute, so let's start now. There's no break time in this. So I'm going to introduce our next speaker, who's the first speaker in Bravo session. We've already met and heard from Dr. Degal, and he's going to talk to us on osmotherapy and traumatic brain injury. Armand, over to you. Thank you.
Thank you. Can you see the screen, or can you, which side are you seeing?
Yeah, we're seeing it. You just need to launch it.
Are you seeing my presentation mode? I think. Let me just.
You have two screens?
Yes. What about now?
Perfect.
Okay. So thank you again, and Peter and Jeff for organizing this meeting. Hello, everybody from beautiful Seattle. I work at the Harbor Medical Center, and today I'm going to talk to you about the osmotherapy in traumatic brain injury. We are somewhat known with the traumatic brain injury sort of care. When I first sort of moved from Nottingham, UK to Harborview, Dr. Lamb was the chief of anesthesia at Harborview, and he sort of got me involved with the care here and invited me to stay. And that was my start to trauma center sort of care in US. Arthur now left us, and he's still working actively, but we are continuing our care and trauma care management. So I would like to talk, as I said, about the TBI and osmotherapy around that. And TBI remains to be a very significant insult to human life. And there are about 5 million cases in North America. And it causes about 500,000 permanent neurologic disability and 50,000 deaths a year. And 8% of these cases are in severe traumatic brain injury. I'd like to give you this example that I was caring for last weekend on my night call, that we received this 54-year-old female T-bond MVC patient. Our paramedic program is very sort of in excellence, and many of these patients get intubated on scene with low GCS and arrive us in a package way. When we get that patient in the ED, the blood pressures were low, the systolics were about 97 with high heart rate, although saturating fine on a ventilator. Her GCS was about 6 with intubation, and she was moving her arms and legs a bit, and a fast scan showed that there was an abdominal free fluid. As we all know, we rushed these patients to the operating room, and which we did, and in the meantime we were giving whole blood volume resuscitation during the case. Again, our pre-hospital paramedic program and our airlift program has whole blood in the units, and that we are able to utilize it in pre-hospital care. In the OR, patient remained to be hypotensive despite resuscitation, and somewhat temperature was low, and the surgery was completed in a damage control fashion with abdomen left open. And we usually do a serotomy in the operating room, again, before we move anywhere else, to check whether there's a head injury because of the nature of the injury patient received, and we identified a subdural hemorrhage with shift in the image. And neurosurgery was on site in the same time, and they did a bolt, and ICP started to read about 28. And they asked us to start a ICP reduction. And the question was, as always, what type of hypertonic fluid would you initiate for these patients? We all know the pressure-volume relationship, and I just wanted to put this mortality indicators for amount of ICP that you may see that if it is about 40, there's a 56% of mortality associated with these patients. This was published by Miriam Trigiari. She is now in Yale. But she was at Harvard at the time that this work was done. Well, hyperosmolar therapy is not new. In 2019, it was the 100-year anniversary of the initiation of hyperosmolar therapy. And the first work was done by Weed and McCubbin from Johns Hopkins, where they show the experimental work to reduce the brain bulk in animal studies. Now we have commonly used two agents, the mannitol and the hypertonic saline. They work differently. Mannitol has increased osmolarity via diuresis and make patient lose fluid. In the same time as you're administering it, that draws fluid from the brain. But hypertonic saline increases serum osmolarity and again draws blood, but without the loss of volume. They both effective in ICP management. They reduce the ICP. And the blood pressure is slightly different in both agents, that mannitol tend to show a bit more reduction in blood pressure with administration, whereas hypertonic saline may keep the blood pressure stable or elevated a little bit with increased volume. There are some adverse effects, and some different in both agents listed here. And one of the things about hypertonic saline generally requires a central line that may be a little bit a challenge at the time of a trauma resuscitation. This is the table to indicate the osmolarity for different agents that we are using for hyperosmolar care. As you see, the saline in 23% is huge osmolarity compared to others and compared to normal saline. When fourth edition in 2017 Tbi Management Guidelines come out, there were a couple of changes occurred in that guideline from the 2007. The ICP treatment threshold changed from 20 to 22, as is in the fourth edition. And CPP targets again changed from 50 to 70 and narrowed to 60 to 70 in 2017. And the blood pressure recommendations were to keep the systolic pressures more than 100 for adult population and more than 110 for youngs and elderly. And this was the statement in the guideline. Although hyperosmolar therapy may lower intracranial pressure, there was insufficient evidence about the effect on clinical outcomes to support specific recommendations or to support the use of any specific hyperosmolar agent. So we still don't know which agent is actually useful. One of the things was that there was no management algorithms in this guideline. We like to see standardized approach to TBI care so we can actually learn from it, as well as provide information for centers who are poorly organized in developing countries and other places. So there was a need for a management algorithm, but didn't exist with this publication in 2017. On the other hand, Guidelines for the Management of Severe Pediatric Traumatic Brain Injury, published in 2019, only talked about the hypertonic saline, not the mannitol, because there was more studies done in hypertonic saline in pediatric patients than mannitol. Here is some indicators again for mannitol versus hypertonic saline modalities. They both act rapidly and their duration action is similar. Mannitol slightly longer maybe, and the doses are used as indicated here. So I just wanted to sort of present you the recent studies being published on this topic. So collated them here in the next couple of slides. And this study was published in 2019 and looking at hypertonic saline versus mannitol for traumatic brain injury. This is a meta-analysis and systematic review, and there was no mortality differences between the two agents. And so they looked at 12 randomized controlled trials. One of the problems with the meta-analyses, of course, is, they are looking at what has been published at the RCT, and there's not much RCT, well-designed and executed RCTs on this topic yet. So authors suffer to sort of make a proper statement at the end of the meta-analysis here to indicate one way or another in terms of agents use. And the Cochrane work being done last year, again, there was only 3 studies being identified to be included in the Cochrane review. And this was again inconclusive in terms of which agent to be used. And authors again indicated the studies are not well designed to form an informed decision and drive recommendation. Another 2020 study. This is from the Japanese Resuscitation Council, Neuroresuscitation Task Force. Again, 105 patients on 3 randomized controlled trials looking at all-cause mortality. Show that maybe a slight favor toward the hypertonic saline, but that was not significant enough to make a recommendation. And there was no significant difference in hospital, 90 days, 180 days mortality, neurological outcome, or ICP reduction and serum sodium levels. So again, another inconclusive sort of meta-analysis being published last year. This is a retrospective study done from the 14 tertiary intensive care units in ICUs, Australia, UK, and Europe, treating severe TBI patients, and compare the mortalities. When the authors looked at the unadjusted hospital and ICU mortality, they seen a significant improvement with the hypertonic saline only patient population. Whereas when they adjusted for key mortality predictors, the significance disappeared. Again, the conclusion was not helping us to make a choice which agent to be used. This last study that from New York Trauma Brain Foundation TBI track database. And in this study, authors just looked at the ICP burden and CPP burden in the intensive care patients. And they identified, as you see with the asterisks here on top of the bars, hypertonic saline patients had more favorable outcomes in terms of cerebral perfusion pressures and ICP pressures between the 1-to-1 match and 1-to-2 match patient groups. And their conclusion was the patients in the hypertonic saline group had a significantly lower number of ICU stays, but 2-week mortality rates were not significantly different between the two groups. And the last study is about the coagulation effect, the hypertonic saline's effect on the coagulation that I want to share with you. As you know, the Resuscitation Outcome Consortium published several studies in hypertonic saline and massive trauma as volume resuscitation agent. Eileen Balger here in Harborview was leading a couple of studies in this topic. And that study was published in 2011 after early termination because hypertonic saline population had a higher rate of death, and the study was stopped as a result. And following 2015, Eileen's group again sort of published another study and looking at the hypertonic saline effect on the coagulation, and concluded that it may interfere with the coagulation and make the patient more profibrinolytic and antifibrinolytic, and may cause further bleeding that may result in increase in death. But this study, Coleman and colleagues published, is looking both in vivo and in vitro population, animal and human models, shown that in the clinically relevant doses, when hypertonic saline is used, does not cause coagulation abnormality. I think instead of thinking around the hypertonic saline as a resuscitation fluid, when it's used for TBI only in a low volume, then it has beneficial effect and doesn't interfere with the coagulation. So after all this, there's like many other things in the TBI guidelines or the way that we treat our patients. There's a lot of unresolved data to make a strong recommendation. I think that was the reason when the 4th edition of TBI guidelines come out, they didn't include any recommendations and management algorithms. To answer that question, in 2019, under the sort of moderation of Dr. Chestnut at Harborview, international group come together to develop this Delphi methodology to generate a guideline for TBI care and severe TBI care. Now the 2 papers come out as a work product from this group that highlighted here. And I wanted to just touch in the fluid side of these guidelines, what they recommended. They have a tiered approach to care. So this is the tier 0 that is common to all TBI cases. And we do that regularly, and there's not much sort of difference than what generally we do. When it comes to fluid, their recommendation was, again, they didn't prefer any type of fluid to one another. So both mannitol and hypertonic saline was mentioned in the fluid hypertonic fluid management. But the point was that they were looking into serum variables of sodium and osmolarity to guide their treatment. So I think that is, again, when you look at the concierge approach, when you back up your work with laboratory values, you have more significant improvement in outcomes. There was another sort of important thing about looking at the patient and measuring variables as you make your management decisions on the patients. Again, MAP challenges were introduced to look at autoregulation and guide the MAP and CPP goals for individual patients. What is not recommended when ICP and brain tissue oxygen monitoring were used is not to use mannitol as a continuous infusion, which we rarely do. And also scheduled infusion of hyperosmolar therapy is not being recommended. So these agents need to be used as a specifically very short term to address the quick reversal of increased ICP. So in summary, hyperosmolar therapy is effective to reduce ICP, but not yet shown to improve outcomes. Gauging the dose and interval is difficult without ICP monitoring and brain tissue oxygen monitoring. And without it, it may lead to overtreatment or undertreatment. As far as we know from the published studies, there is no one hyperosmolar agent is superior, but institutional familiarity is important because keep changing between the two agents may cause some confusion in the care of these patients. Infusion appears to be superior when multimodal monitoring is in place. So blind mannitol administration is not recommended. And hypertonic saline, due to its volume advancement opportunity, may be advantageous in hemorrhaging trauma patients. So that is again something to take home with instead of mannitol. We desperately need further research for right choice of agent. It is dose, duration, and timing of administration. And then we also need to establish the care with hyperosmolar treatment and its relationship to mortality and neurological outcome. There are a couple of studies ongoing right now that we need to keep an eye on for. There's a COBE trial, completed their patient collection, and hopefully they'll be publishing their results soon. We need to keep an eye for. And also the SOS trial, sugar and salt trial, that is coming from Europe that we are looking forward to see the results. There's another meta-analysis being conducted, and their study protocol is published this last year, and we're looking forward to their results. And an ADAPT trial for pediatric brain trauma foundation that is going to publish their results soon. So these 4 things to look forward in next coming months. So this concludes my presentation. And again, I just want to mention that if you're not already a member of the task, please make sure that you check out our website and join us in the trauma care. Thank you.
Thank you, Arman. We're obviously running slightly ahead with your with our program. So in an attempt to save some time in the panel Q&A, which is scheduled for 11:15, maybe you'd be prepared to answer a few questions at this point.
Sure.
So I've got one question for you. In fact, I've got 2 questions for you. The first one is regarding hyperosmolar therapy. Which do you recommend, continuous infusion or an intermittent bolus?
Well, we do, as I said, continuous infusion is not recommended. So we are doing intermittent boluses with the 23% hypertonic saline when we see the patient requiring volume resuscitation. But we do hybrid mechanism. Our center and ICUs are very well sort of equipped with using both agents. And we see, patient coming from the ED with mannitol and changing into hypertonic saline. And we are taking blood samples to look at osmolarity and sodium levels, again, guide our decision which one to use.
Thank you. Dr. Barron's asking a question. What about TBI patient who is also hypovolemic? Are there any studies that compare mannitol versus hypertonic saline?
This is one of the crux of the work that is missing. Unfortunately, there is no well-conducted studies on hypovolemic patients requiring a hyperosmolar agent and preference of one or another. But from the animal studies and the volume benefit of hypertonic saline, it looks logical to prefer hypertonic saline in this patient population compared to mannitol. Thank
you, Amma. So I'm going to move on to our next speaker in Bravo section, which, considering all 3 speakers are from Harborview Medical Center, I should have called it the Harborview session. So it gives me great pleasure to introduce Dr. Bentov. Itai is an associate professor at Harborview Medical Center and also a former medical officer in Israeli Defense Forces. So Itai, please take it away.
Can you see my screen?
We can, thank you.
All right, so I will talk to you about anesthesia for geriatric trauma. This is usually, when I start talking about old people, that's usually when I lose my audience. So let me try to convince you that this is relevant, not just for the book of Job, but for anybody else who's actually providing trauma anesthesia. And I am trying to click. Why is this not moving? Here we go. I do have financial disclosure. I am funded, and I will present stuff that was funded both by the NIA and by the UWRRF, and also by medical students that spend the summer with us, in which I'm the co-site director, but I will not discuss any investigational use. So if you look at the 2018 US Census, we have over 50 million persons who are older than 65. Over 20 million of them are older than 75. And by 2030, we assume that we will have more than 70 million people in the US alone who are older than 65 years old. And in this group of patients, trauma is the 6th leading cause of death. And the numbers are increasing, and everybody's heard about the silver tsunami. We can see it all around us. Anybody who's a trauma anesthesiologist will have to take care of elderly people who are injured by trauma. And you know, we go back to how we were brought up. So I recently, because of the last year, read Albert Camus' The Plague Again. And there's a lot of suffering in this population that maybe we can help alleviate. And I think that's our role. The outcomes in aged trauma patients are definitely worse. Mortality is up to 4-fold higher than the same patients, the patients with the same injury severity score. They have unfavorable discharge disposition. They're discharged to SNFs, and they have reduced quality of life. They take a lot of resources, and we must do better when we treat these patients. But when do we really start thinking about when is geriatric really geriatric? I love the graph, the graph on the left that shows that the functional reserve is lowered with age, because it's a very explanatory graph. But it says absolutely, it's not a real graph from the real world. It talks about a hypothetical concept, functional reserve, but we can see as it slowly goes down over age, the functional reserve, we know that even a simple injury can take somebody who's elderly and completely take them out of their usual life and maybe not being able to recover from that injury. And the big question is, when does elderly start? And I don't think it's 65. I don't think it's 75. I actually think when we look at case fatality rates in these population, I want you to notice that there's an inflection point that starts here around age 55. So I know I'm there. I think that other panelists are there as well. I think it's relevant. And yes, it's not as bad as being over 85, but at 55, if we're injured by a trauma, we die more. This is true we can see that for COVID as well, but for different diseases, we can see different ages of inflection points. But I think you need to keep in mind that at 55, people start dying more. The classical story that everybody is trying to avoid. If you're a trauma anesthesiologist, you love the big laparotomies and craniotomies with lots of blood and a lot of, but there are over 300,000 cases every year in the US alone of hip fractures. And anybody who treats these patients, anybody who's a trauma anesthesiologist will have to treat this. And we have discussed back and forth, should we do them in regional? Should we do them in general? And you know, basically you ask a resident what is true about geriatric anesthesia, they will usually come up with two things. Start low and go slow, and maybe avoid benzodiazepines. I don't think that's really the answer to how we make this population live better. And we go back to the geriatric consultation, to our friend the geriatricians. This is a study by Ed Marcantonio from 20 years ago. And he said, what do I provide as a geriatric consultant? I tell them how to maintain the blood pressure, saturation, crit, I mobilize the patient ASAP, I provide the appropriate environmental stimulation, and I minimize a certain number of drugs. And by that, I actually improve outcome. Well, this is what I do before breakfast. I do fluids, I do temperature, I do oxygenation, I do blood pressure, and I put a list that shows that by doing these things, this is what we do as anesthesiologists. And by doing them, I actually improve outcomes on these patients. So I don't need anything more than this. Not really, not so fast. Well, let's look at it. Fluid management, we know in the elderly people, can improve outcomes in the older population more than it does in the younger population. Problem comes that clinical signs of intravascular volume status are often difficult to evaluate in older patients. So we know that we need to fine-tune them, but doing it clinically is actually a problem. No problem, we're anesthesiologists. We have a ton of toys that we can just use. And I took this rock curve about different tools and how well they perform. And as you can see, some of these perform extremely well. Continuous monitoring of beat-to-beat basis or pulse contour analysis is the answer, right? Not so fast again. Well, it's been known for since 1954. This is a 1954 publication. Well, there's an age-related nonlinearity of the arterial wave contour due to aortic compliance. And there's a more recent finding from a study showing the radial pulse contour or the carotid pulse contour. And as you can see, and you're going down decades of life. And as you can see, if we, by the time we reach the 8th decade, it doesn't look anything like where we study these patients. And some of our patients are in their 9th and 10th decade. And you know, this study was stopped on the 8th decade, but really, some of our most problematic patients are way beyond that graph. And when you look at specific population, you realize that those things that we use to flow track, you know, I'm not talking about specific things, but the point is, let me go to the Bolden, does not reliably track changes, or the degree of error and unreliability is higher than that considered acceptable. So fluid management may not be so easy. Hypothermia, yeah, we need to protect it, but we don't know when they're hypothermic, we don't see the clinical signs, and rewarming once they got to be hypothermic is much more problematic. Should we administer oxygen? Yes, we do, and we want to make sure that the oxygen gets there. The problem that as we age, oxygen transport is diffusion limited, and the tissue oxygen uptake in the elderly is reduced. So although we can get the oxygen over there, they usually cannot use the oxygen that we're getting over there. Well, blood pressure. We all love blood pressure. We all love to control the blood pressure and make sure that our charts look like the hypothetical chart that I think we could only get when we were doing hand charting. But the fact is, now that we have electronic charting, most of our charting, especially in the elderly trauma patients, look like this mountain range. Blood pressure goes up, blood pressure goes down, it's everywhere. Why is that? The reason is because there are connective tissue changes that lead to loss of elasticity and electrophysiologic changes and myocyte death, and mostly because enhanced sympathetic nervous system activity at rest, which is true as we age, causes a decreased response to adrenergic stimulation when we need it most. So the problem is that we have microcirculation, and microcirculation is everywhere. And in that microcirculation, whether it's in the kidneys or in the liver or in the skin or in the heart or anywhere, we see these age-related microvascular changes. And they're happening at every level that we are checking. And the fact of the matter is, we are never checking microvascular flow as an anesthesiologist. We are checking macrovascular flow, but microvascular flow, no. We only see it after the consequences are there and already affecting our patients. When we have created a debt rather than before we can do, but rather than being able to provide the treatment that we would have liked to. I want to talk a little bit about the skin. We know that skin, I mean, it's pretty easy to see which one of the picture is the young person and which one is the older person. And we know that wound healing is impaired. And I want to show you that there are descriptions from 1916 that show us this. I found this on Journal of Experimental Medical. So over 100 years ago, we know that skin is changing, and you can see that the changes are even in the structure of the skin, and elderly skin tends to shear more and tear more. But the point is, if we look at even the basic blocks of the skin, the fibroblasts, the things, those cells that need to move into the skin to actually into the wound to deal with the wound, even those, you can see here, we took young and elderly fibroblasts. And if you're interested in molecular biology of the response to trauma, you would come up on a protein called ERK, which is a protein that gets phosphorylated to be activated and is very important in growth and in response to damage. And it's a universal thing. It's not just in the skin. It's the same thing is true when we're dealing with TBI or when we're dealing with cardiac damage. When there is damage to the skin, when there is damage to the cell, we have growth mechanism to try to repair it. And as you can see, the total amount of ERK is not different between the young and the elderly people, but the activation of ERK is very, very different. In addition to that, I love the way that people talked about concierge service, because I worked as a waiter through medical school, so concierge service is wonderful. And the point is timing, and the previous speakers have talked about timing as well. So when we look, for example, at wound healing, we see that there is initially inflammation, but then there has to be proliferation and tissue formation, and then remodeling. And all of these things can potentially be affected by our anesthetics. The granulation of, basically you've talked so much about inflammation, but the end of that response does not, the response to that does not end at that stage. And our anesthetics and our pain management and our fluid management can affect all of these things. And it's very important that we recognize these changes and that we use our expertise to help the injured persons as they go through this journey. But the big problem for us is really not just identifying the time, but really identifying who needs it more. Because age, some people are really affected by it horribly, and some people age so well. I've put on this slide, all of these persons are roughly the same age on this slide. Some of them look good. Some of them have just finished their 101st marathon, and one of them has climbed the Everest. One of them, by the way, was, I realized that I'm telling you what a geek I am, but one of them was, my childhood hero. This is Leonard Nimoy right here being wheeled through Dr. Spock from Star Wars, for those who don't know that. Wheeled through LA airport just before he passed away. And he's nowhere near looking like, what embalms logic and strength. He can't really run a marathon or go over an Everest. So can we identify early who's at risk and provide more care, more maybe targeted approaches, concierge approaches to these patients. So I'd like to for you to consider the concept of frailty. Frailty is a biological syndrome of decreased reserve and resistance to stressors. And frailty leads to adverse outcomes. It's not just in the surgical phase or in the trauma phase, but how many more stressors are there than surgery and trauma for an elderly person? And when Linda Fried first coined the term frailty, she said, well, frailty is not the number of comorbidities, that you have. Neither is it the disability. Yes, when you look at this Venn diagram, you can see that there is a lot of areas that correlate between those two, but they're not necessarily mutually equivalent. And when I say disability, it's activities of daily living. Can you wash yourself? Can you move? Can you feed yourself, etc.? Comorbidities, you know very well. Do you have diabetes? Do you have heart disease, etc., etc., etc.? But now comes the question of what is frailty, which is, again, there is an overlap, but it is a distinct concept. And we have a lot of ways to address and assess frailty. And some of them have to do with, I don't know if you can see this, maybe the writing is a little too small. It has to do with weight loss and exhaustion and slow gait speed. I mean, these are the people that we almost recognize by eye. They come to us, they're slow to move, they lost weight, they look slow, they very often the mood is down, they suffer more from catastrophizing, for example, something that we are describing now. So we have tools to identify these patients, and there are numerous tools. Right now, there are over 80 different tools. Here are just some of them. And no matter which tool I use, whether it's the frailty phenotype or indexed, or some of them are even app-based, they do worse. So I chose one for every tool and every outcome. But the fact is that in 23 studies using 21 different instruments for frailty assessment, all the frail patients had higher mortality at 30 days, at 90 days, and a year, roughly a 2 to 3-fold higher mortality for all of them. They had higher complication, greater length of stay, more discharge to an institution. And discharge to an institution in the elderly population is very important, because those that are discharged to an institution die more and have a worse quality of living. So they everything about them, including their function, including their quality of lives in these frail patients, is worse. But you'll be asking me, which one should I use? I'll tell you, we have implemented, again, at Harborview, a very quick, simple thing to use. So all the patients who are coming through our pre-anesthesia clinic, there is a frailty tool that was developed in Deloitte in Canada by by Ken Rockwood. And what he said is, just look at the patient. You can see a pictorial over here. Is the patient very fit? Are they very frail? Are they severely frail? My wife has noticed that all the fit are men and all the frail are female. That's not me, but it is very easy to use. It takes literally 30 seconds to use this tool. And it actually, as we have just published, it actually predicts mortality in the general surgical population fairly well. But then you will be asking me, okay, so I diagnose frailty, but what do I do with it? I tell the person that they're going to suffer and die and be institutionalized and all these horrible things. Well, I want to show you, this is a very interesting study that was performed by Jason Johanning from Nebraska, from the VA at Nebraska. What he did over there was basically a factory of frailty assessment. Patients came in before they started frailty assessment. And as you can see, some patients did very, very well. But the patients who assessed for frailty did very poorly. You can see their cumulative survival. And again, this is there are a lot of problems here. As you can see, the graphs are not exactly showing the same numbers. So this is 1,000 days over here after frailty assessment. This is 3,000. But even if we census the graph right here at 1,000 days, the same graph is here, okay, 1,000 days, you can see that there is a big difference. And what he did basically was say, when we identify frailty, we need to talk. So the surgeon, the anesthesiologist need to stop and they need to talk. What will they do afterward? It doesn't matter. Will they change the type of surgery they perform? Maybe. Will they send the patient to get more nutrition before coming for surgery? Yes, maybe they'll cancel the surgery altogether. And as you can see, in those that are frail over here, the mortality was reduced significantly. So I think just by knowing that somebody is frail, knowing that you have to provide a more dedicated approach, even not knowing what exactly that approach, even not being able at this point to provide a molecular solution. Because what I suggested to you is that there are all sorts of things that are happening on that we can potentially influence. But even just knowing it without prescribing a specific intervention was good enough to reduce mortality. But then you'll be asking me, wait. You talk to the patient, you let them walk, you send them home for nutrition. I can't do that in trauma. They're right here. We need to operate on them. I can't even assess frailty because on most of my patients, I can't even talk to them and get information and ask them to do all these tasks. So I think as trauma anesthesiologists, we need to first identify those that are frail and those who will receive those interventions. And after that, we can potentially stratify them according to molecular mechanism and potentially offer this, because this probably will not be able to be provided to everybody in the current thing. So how can we, as an anesthesiologist, identify those that are frail in trauma patients? Ideally, we love to look at blood results. So as you can see, I put a long list of things that we routinely check, and we would have loved to see the effect of these things on being able to assess frailty. The problem is they don't really work. They have, yes, it does provide some information, but the answers are not robust enough for us to identify these things. And this has, again, a list of references showing why this is somewhat informative, but not enough. Then we say, okay, again, I told you that I was trained as a molecular biologist, and maybe we can look at molecular mechanisms and identify. And aging involves all these molecular mechanisms that, by the way, are you will recognize them from your trauma literature. They're talking about inflammation and oxidative stress and mitochondrial dysfunction, et cetera, et cetera. All these things appear in aging, but there is a lot of convergence when we're dealing with trauma. And what we can do is check pro-inflammatory cytokines, IL-6, TNF-alpha, tumor necrosis factor alpha, indicators of oxidative damage, my own favorite molecule. You know, every molecular biologist has their favorite molecule, insulin-like growth factor 1, which I can show you how important it is in trauma and other things, and sirtuins. And there's been a lot of work. And yes, it does provide some information, but still not good enough, not specific enough. And probably because these are laboratory markers that you would get the answer maybe a day or two after you sent, not useful enough for us as anesthesiologists. So what do we need to do? Let's go back to how aging works. Well, I talked to you about all these mechanisms that happen that cause frailty. And I said that this acute stress surgery will cause adverse outcome. But frailty also, which again, I told you, will lead to loss of strength and reduced activity and reduced metabolic rate and weight loss and loss of appetite, will also cause another thing, sarcopenia, or loss of muscle mass and function. So is that useful for us as anesthesiologists? Do we even assess sarcopenia? And the answer is yes. Almost no patient will arrive to us without some radiologic studies. So for example, this is a standard abdominal X-ray. This was not done by us. And we can check the amount of muscle within that CT slice. We thought that that was really exciting because we can do that. And we started thinking about specific muscles that we could look at, because looking at all the muscles and really doing the calculation, let me go back here, how much muscle, it's very difficult for us to quantify unless we have specific software, but we need to provide a tool that is useful and easy to do. So we started to look at specific muscle. And the first muscle we looked at was the psoas muscle. You can see it right here. And this is what an abdominal CT looks like. You can identify the kidneys right here. And this is the psoas muscle. It's a hip flexure, very, very easy to identify. How easy to identify? First-year medical students, because the studies that I will show you were done by first-year medical students who came to us in the summer. So we took a retrospective cohort at Harborview. We took a little over 550 patients who are older than 65 and admitted to our ICU over roughly a 4-year period. And they were not severely injured. Some of them did not have CTs. Some of them, CTs were not perfect. But we had about 450 patients in our study cohort that we divided. And we divided them into 4 groups. They could either have, as you can see here, you can see a muscle mass. You can see the psoas muscle mass. This is a nice, robust muscle mass. Or they have a short muscle mass. And they had either a strong bone, so they have osteoporosis right here, you can see, or a small bone, right? Or just a weak bone, if you like. So not a dense bone, sorry, not a small. A weak muscle, a small muscle, and a weak bone. So we now have 4 groups: those that have normal muscle mass, those that have abnormal, or those that have both normal and bone, normal muscle and bone, one of them abnormal, and those that have both abnormal bone and abnormal muscle. And we can follow them now for a year to see what happens to this. And this is what we found. If they had normal, and again, this is all comers. If they had normal, and again, this is not minor trauma, this is trauma that got them to the ICU at Harborview. If they had normal muscle and bone, this is their Kaplan-Meier curve. Almost none of them passed away. If they had one of them that was different, this is how they passed away. And if both of them were different, both of them were abnormal, this is how they died. So just by having a CT scan, a single slice on their admission CT, we didn't do a predictive model, so I would not say predict, but we could inform ourselves something about what will happen to them a year later. But you're saying most of our patients don't necessarily get abdominal CTs, many more at Harborview, and I put in the numbers. They get much more head CTs, because when elderly people fall, you need to give them a head CTs because signs of intracranial trauma are very often absent. So they get head CTs. So what we did over here, again, go back to the muscle. We chose the masseter muscle. It's a muscle mastication. And we looked at their brain volumes by looking at the intercardiac ratio. So basically, as people become more, their brains become more atrophy, the size of their volume, and we wanted, again, something that a first-year medical student can examine. And so again, 4 groups, normal for both of them, abnormal for one of them, abnormal for both of them. And again, doesn't matter which CT you use. It could be head, it could be abdomen, it could be chest. We did the same thing with just muscles of the chest. That's what we see. Those who are sarcopenic die more. So why am I telling you all of this? Because I think we have a unique opportunity as an anesthesiologist to influence this. And Jeff, I will be done on time. We use ultrasounds. POCUS is the new thing. Everybody uses ultrasound. We use it to access vessels. We use it to do nerve blocks. We do them for TEs or TTEs. We can do the same thing for muscles of the face. So if you swing your probe right here, you can actually get a pretty good picture of the size of the masseter muscle mass. And in addition to getting the ultrasonographic picture, we can also see not just the size, but we can see potentially. And again, I do not know if it's true. We are just looking at this right now. We can see the muscle contract. And maybe the same way that children, look at Popeye and you can see the muscle pop up, maybe we can do the same thing for relaxation and contraction of different muscles. Right now, we're looking at the masseter because it's so superficial, so easy to get to us as anesthesiologists. We're right there. So I think we need to examine these things. So again, my email is right here. I think this is an endeavor that involves all of us. At Harborview, we created a geriatric injury work group that includes geriatricians and surgeons and orthopedic surgeons and people from the ED. And these are questions that I think we need to participate in. We need to tailor our approach. We need to first identify those that we need to tailor our approach to. And we need to, secondly, be able to influence different molecular stages as we move along. Going too slow, just start low, going too slow, or avoid benzodiazepine just doesn't cut the mustard anymore. We need to do better than that. And I think I'm done with. And again, I didn't start by thanking Jeff and Peter for getting this panel together. Thank you, and I'm sorry we can't all meet in Chicago.
Itai, thank you for a wonderful presentation. You've definitely carved out a niche for yourself there with geriatric trauma. I'm going to now hand over to our next speaker in this Bravo session, and that's Dr. Paul Bala, who's an assistant professor also at Harborview. Paul was formerly appointed as an attending or a consultant anaesthetist in the UK. So Paul, over to you, sir.
Thanks, Jeff. Can you see my slides okay?
Yes.
Perfect. Okay, thank you, Jeff, and thank you, Peter, for this opportunity to speak. The weather in Seattle is not like this background, and I just wanted to say before I start, Jeff, we miss you here. I hope you come back sometime. So my name is Paul Balla. I, like the other speakers in Bravo's session, hail from Harborview Medical Center in Seattle. My area of interest is perioperative pain. I work in the OR and I also work on the acute pain service and on the regional anesthesia service. And I'm going to talk, I'll keep this under 30 minutes, about pain and particularly regional anesthesia and trauma. And no disclosures this time. So what I want to do is talk about this really against the context of my experiences training in London, running an acute pain service in an orthopedic hospital in London, and then coming to this large level 1 US trauma center. So, you know, I know most of this audience are trauma people. These kind of scenes aren't very surprising. They're very familiar to us, these kinds of headlines. This is Harborview here with Lake Washington in the background. And the reason I put this up is the sessions we've had before, we're talking about this immediate golden hour, saving lives, saving limbs, these helicopters flying in and out, these busy trauma bays, and that rightly so is our priority. And I think, as someone mentioned before, now we're surviving trauma more. Survival's improved dramatically from safer cars, cutting edge pre-hospital care, body armor advances in military. We're seeing more of these survivors and they have long-term issues, and that includes pain. So we're familiar with the immediate consequences of pain in the hospitals: agitation, catabolic stress response, poor breathing, DVTs, immunosuppression. Long-term repercussions of acute trauma pain are also evident. So we know that further down the line, poorly controlled acute pain leads to long-term disabling consequences, so impaired physical function months along. We know, and from my experience of chronic pain, clinics are filled with people who have survived trauma and have long-term complex pain issues that are often associated with disability, with job loss, and also with addiction. And then the psychological consequences of poor pain control, we see evidence of post-traumatic stress disorder relating to poor acute pain control at the time of the trauma. So this is a really simplified representation of the cascade of early pain. And what we see is that the acute injury causes activation of peripheral sensitization via a neurogenic inflammatory response. And this is with surgery or trauma. And then if that nociceptive barrage persists, then we get an activation of the central synapses within minutes to hours, and that causes central sensitization, wind up, and this phenomenon we see, such as hyperalgesia and allodynia. And then within hours to days, our natural descending modulation pathways, the filter for pain, the kind of, I like to think of it as a volume control that we can use to turn down pain, becomes overwhelmed and is failing by then. And so pain tolerance of patients decreases, and if this is left unchecked, it leads to persistent pain even after the healing of the initial injury has occurred. So that's any surgery. Why is trauma different? Well, obviously we missed the boat on this early stuff. We see patients after the injury, after this bit, maybe down in the central sensitization bit. We know trauma is associated with an exaggerated inflammatory response. So there's a high nociceptive load on patients, and then we go further. We take them to surgery for damage control, and their modulation filter is already struggling. And as well as all of this, I wouldn't be a pain guy if I didn't mention the whole biopsychosocial model, but this is John Loza's model from Seattle. So we talk a lot about pain in the middle, but trauma as well really amplifies the other parts of the biopsychosocial aspects of pain. So traumatized patients have higher levels of psychological stress. There's a social impact, there's a loss of income, there's a loss of status, and these all combine to make the trauma pain experience much worse than anything we see in elective surgery. So what tools do we have to manage this pain? Well, I'm here to talk about blocks, but I'm not going to be too evangelical about them. They're useful as part of a multimodal approach, and that's really why it's difficult to figure out what works and what doesn't. We have so many tools, and I think what we invoke with this multimodal analgesia is this concept of marginal gains, which I'm sure you're all familiar with. I'm recently getting into cycling a little more, but I remember this concept was all the rage, at least in the UK, about 10 years ago when Brits were winning all the cycling, the Olympics and the Tour de France. And this man, Sir David Brailsford, was credited with it because he really passionately believed in this marginal gains concept. And it's also the concept that drives our enhanced recovery protocols. So what Sir David Brailsford did is just take these tiny little things that are involved with cycling. He took it even further than this. He was teaching his cyclists he was using surgeons to teach them to wash their hands so they wouldn't get sick. He had special seats in the van so they wouldn't get injured. And all of those gains help. And when we translate that to pain, I think while regional anesthesia is a part of it, there's lots of things that are important. So simple things, traction, splinting, simple analgesia, heat pads, cold pads. Psychological support is really important. And we see that on our pain service. We have a dedicated full-time psychologist. Surgery itself, damage control, debridement of burns, fixation, and then obviously the pharmacological stuff, the non-pharmacological stuff as well, and then regional fits into that. And I think the important thing is that for these strategies to continue throughout the healing period. So this concept is really talking about preventive analgesia, which I won't go into too much, but we miss the boat on the preemptive side, so in trauma. So we can't take away pain relief before the trauma has happened. But the idea of preventive analgesia is to continue to reduce that nociceptive bombardment throughout the period of those spikes of intensity. So when patients are moving, when they're having more surgery down the line, and do that throughout the whole period of healing. And that's really why it's hard to tease out what works and what doesn't. So while I'm not evangelical about blocks, I am a little biased, and I do think there's an argument that regional is an ideal method of providing pain relief. So it's very targeted. I mentioned that a lot of trauma is extremity trauma. Limbs are pretty simple to block. Regional has minimal systemic effects. Things we worry about, Ite just talked about old people, and so things we use nowadays, ketamine, opioids, gabapentin, they're all they all feed into sleepiness, confusion, delirium, and particularly opioid avoidance has become a hot topic in the last 10 years with the opioid crisis. And we know that trauma patients end up having a higher preponderance of dependence and addiction to opioids. Things that the hospital cares about. So yes, regional anesthesia can provide for a shorter hospital stay, particularly if patients can go home while their nerve block's working. There's some evidence of improved outcomes, and while it's not great, and some of that lack of evidence is as I said before, down to the fact that we can't study one modality during one period of time along that whole trauma continuum. So when we look for evidence, it's kind of hard to tease out. We can look at experience in the military, and that's generally positive. I know Dr. Buckenmeyer, one of the authors on this paper, was meant to talk at this conference in Chicago last year, and he recently published his paper with his colleagues in 2019, looking at 358 military casualties who received early regional anesthesia, early meaning within 1 week of trauma or standard care. And what they found was after they adjusted for length of stay and injury severity score, there was a significant association between that early regional and reduced average pain intensity. And this continued, this graph goes, I know this is small, goes on for 24 months. And while these numbers on this axis are small, this is just the brief pain inventory interference score. The numbers are small, but there is this change with early regional anesthesia. Other authors have published on the benefits of regional in the military. So this review from the Global War of Terror concluded that there are significant benefits to the use of regional anesthesia in polytrauma patients. This is from the UK, the Royal Centre for Defence Medicine in Birmingham. I think actually Jeff used to work there. So they have developed a whole checklist for trauma survivors to manage pain in a multimodal way. And just zooming in on number 5 there, regional epidural analgesia are used pretty aggressively, and they really rely on indwelling peripheral catheters that they actually use for weeks at a time to cover that whole healing period. my experience, the civilian experience, that's got good literature too, although much of it focuses on the paradigm of hip fractures because they're easy to study and they tend to be in an older population that we know don't do well with systemic analgesia, and we look at alternatives more aggressively. And I think this was mentioned earlier, where I train in West London, our trauma lists, the idea of trauma was a list full of older people with hip fractures. And this particular study is one of the larger systematic reviews of regional nerve blocks for hip and femoral neck fractures, but there's many out there. And many medical systems nationally and locally have moved to strongly advising early femoral or fascial iliacal blocks in the ED for this older population with hip fractures, because it makes such a big difference to these people who already have an incredibly high mortality rate. So you can probably tell I've talked mostly about the limbs, the extremities, and the evidence out there is there, partly because lots of trauma affects the extremities and they're easy to block, and partly because until recently the trunk was just not as amenable to regional as the limbs. So the other big experience we have in trauma amenable to local is chest trauma, so particularly rib fractures, and that's by far the most common chest trauma that we see that's amenable. So for many years, the epidural has been seen as the gold standard, with many papers coming out, particularly from our own institution. So Eileen Bulger here produced papers showing that it was superior to morphine alone for the management of rib fractures. And then the Eastern Association for Surgery and Trauma conditionally recommend epidural for the early treatment of rib fractures, although they do admit that's based on poor evidence. And really, when you take a good look at the evidence out there, it shows that epidurals are superior for pain relief, but they're not really shown to be that helpful for length of hospital stay or mortality or pulmonary complications. And that's not to say the reduction in pain that they show isn't valuable. I've already talked about the importance of early pain control, reducing that nociceptive bombardment. But the problem with trauma epidurals is that, frankly, they're a little terrifying. And we get a lot of calls on our APS from our trauma intensivists asking for help because they're trying to prevent a patient with respiratory failure from painful rib fractures from deteriorating and getting atelectasis and chest infections and all of those other horrible things. But when we look at these patients, they're often coagulopathic from the trauma and from the iatrogenic coagulopathy, the DVT and PE prevention. We find epidurals are really technically challenging to place in intubated patients on an ICU. They're full of lines, turning them, positioning them. They often have other injuries of the spine or around the spine that make it difficult to find the right spot. The tissue is edematous and traumatized, and the feel, epidurals are still done as a blind technique, and it's difficult. And then even when we get them in, our experience is that they're stopped pretty quickly. They cause hypotension, urinary retention. We don't like that the patients are weak as they start to recover, or they just fall out because the patients are sweaty and they move around, and we just can't keep them in. And then consent of these things, because of these risks, we're more worried about getting an adequate consent, and that's very difficult with these patients. So really the end result is that we hardly do any thoracic epidurals in trauma at Harborview, and we've really replaced our neuraxial blocks, at least as a first line, with trunk blocks. So on the left here, we've got our traditional blocks. These are the ones that everyone knows, blocking the extremity, the neuraxial blocks, epidurals and paravertebral blocks for the chest. In the last probably decade, we've had this explosion of described trunk and fascial plane blocks. And that's partly because epidural technology has improved. The images we get are so good now that we can, as well as just seeing blood vessels and bones, we can see individual muscle planes. These planes are easy to place catheters in. The coagulation isn't such an issue, and you can be a little creative with where you go if there's something in the way, if there's some trauma in the way or a chest tube in the way. The volume concentration of these aren't necessarily established, but we are doing them, and there's lots of worldwide experience now gathering. So I'm going to spend a little bit of time talking about these blocks. The first description really was in 2013 from Raymond Blanco, who described these 3 different chest wall blocks to numb up the anterolateral chest wall. These all are aimed at placing local anesthetic either above or below pec major and minor, or further laterally above or below the serratus anterior muscle. And over time, since that 2013 literature, there's really been an acceptance that all these three blocks are basically doing the same thing. They're blocking the lateral chest wall. And they've been shown over that, 8 years to be safe and effective and technically much less challenging. So this is what we do often for first line for rib fractures. So patient doesn't have to be moved. It can be done supine. We just abduct the arm, scan in the anterior axillary line, and we're looking for the serratus anterior muscle. That's kind of a wavy muscle serrated under the, over the ribs. Latissimus dorsi overlies it, and we place local anesthetic between the rib and the serratus. And what that does is we're blocking this lateral cutaneous branch of the intercostal nerve as it perforates the serratus muscle. So we can place local either here or above the serratus anterior. And as you can see, this gives you a block of the anterolateral chest wall pretty reliably. So this is one of our burns patients who had a serratus anterior block placed after pain from a pretty aggressive debridement. And we successfully helped their pain. Our own institutional data, when we use it for rib fractures, we just published some very brief pilot local data with some small numbers. So we looked at our first 14 patients back in 2016-17 and then matched them to patients who had had epidurals historically, who fell into similar injury severity patterns and other demographics. And even with these small numbers, we found that the indication was that these are as effective with outcomes like pain scores, opioid use, and for intubated patients, we used their rapid shallow breathing index and time to extubation. And there really wasn't much difference between epidurals and serratus, but the overall technical ease of placing these meant they were much more acceptable, and we were doing a lot more. Moving on, so more recently described as the erector spiny plane block. So this is another very useful trunk block, still awaiting, like all of these things, good RCT data, but there's plenty of local and national and international experience and case reports of its effectiveness in thoracic surgery and in rib fractures. So what we're aiming for here is to get the dorsal and ventral rami both of the intercostal nerve by placing local anesthetic underneath the erector spiny group of muscles and above the transverse process, so just at the costotransverse junction. And then what we see is this kind of pattern of spread. So this is from this rib fracture case report. So this really nice hemithorax is blocked from front to back. Now, obviously the patient needs to be positioned pretty similarly to an epidural, but it is a lot more forgiving as to what level you go in at. And there seems to be a lot better cephalocaudal spread than an epidural or a paravertebral, and less of the sympathetic effects. The quadratus lumborum block is again a novel block for the anterior trunk. So it's being used increasingly over tap blocks because of the superior abdominal wall coverage. I won't go into too many anatomical details, but there's this really complex, anatomists get very nerdy about these thoracolumbar fascias and how they behave. And with the QL block, we're aiming to place local either in front of or behind the quadratus lumborum muscle. And what we get with that is reliable block of the ilioinguinal nerve, the iliohypogastric nerve, and the genitofemoral nerves. But then we're also potentially spreading muscle up along psoas and QL to get paravertebral areas and intercostals. So we get this really nice spread of the anterior abdominal wall. And what we're starting to use that for, so again, we get a lot of burns in Harborview, and this would be a perfect thing for a QL block. I think this patient got a single shot with good pain relief. And we're also looking at using them in pelvic fractures. We're just having that conversation with our trauma pelvic surgeons now. And then I'm doing this in order of blocks that are a little more cutting edge, but with way less evidence backing them. So more recently, people are using retrolaminar blocks. So this is I'm describing, so I really want to give you a complete picture of how diverse these trunk plane blocks are getting. So for minor spine trauma, the retrolaminar block is quick and easy. It's been described for elective lumbar spine surgery, but there are case reports emerging now of its description in painful fractures, the transverse process fractures and vertebral body fractures that are non-operative. It's performed more medially to the erector spinae block, so literally just a needle coming down onto the lamina and only getting the dorsal ramus, and so much more localized to that strip of the back. And again, it's something we're looking at developing in Harborview. And then finally, sternal fractures can be exquisitely painful and resistant to analgesia. The transversus thoracic plane block aims to place local anesthetic above this transversus thoracic muscle. So, excuse me, we're going below the intercostal muscles and above this transversus thoracic muscle, and trying to catch the anterior branch of the intercostal, the anterior cutaneous branch as it supplies the sternum. And good descriptions for that in sternotomy and elective surgery, cardiac surgery, and emerging reports of it being used for traumatic sternal fractures with good effect. So you can see I like regional, I like doing it. What stops me from doing these blocks more and more in our level 1 trauma center? What are the barriers? So I've sort of divided these up. Common barriers for us in the top left are coagulopathy, which I'm going to talk about a little more in the next slide. And then practical issues of timing, consent, and patients who are sedated that just institutionally just limit how many blocks we can do. Then the things in the bottom left are the things that our surgeons worry about, and rightly so. Things like compartment syndrome, patients having motor block and not being able to move afterwards. Our burn surgeons in particular worry about that. Our trauma surgeons tell us that it's all very well, we place single shot blocks and then the patient is packy, really happy, and either at home or in the middle of the night, these patients get horrible rebound pain when their blocks wear off. And so I think there's an argument that we'd rather almost know what they're going to feel like as they wake up and deal with it then. In the top right are the things that we block people worry about the most. They're exceedingly rare but devastating things are local anesthetic, systemic toxicity. And we've had one of those with a burns patient. We worry about nerve injury, which is very rare, and it's hard to tease out from trauma, particularly where there's a high risk of nerve injury anyway. And then we worry about infection, again, very rare, but hard to tease out with trauma. And then the things that we all fret about, this lack of evidence that's solid RCT data, and the lack of even local QI data. It's hard to have a robust discussion with a trauma surgeon about, say, blocking a tibial plateau fracture when they are really properly worried about compartment syndrome, and I don't have good data to show the benefit of a nerve block. It's not going to be an easy argument to win without good data. So I mentioned coagulopathy. This has been a huge problem for us at Harborview, and I know other centers have experienced this. The national guidelines in the US were really, for peripheral analgesia, were extrapolations of the pretty restrictive, appropriately restrictive neuraxial guidelines, but they were just too strict for peripheral nerve blocks. The epidural space is this enclosed space, so any volume there is going to create lots of pressure and risk damaging the central nervous system. We don't have that problem peripherally, but we were hindered by these guidelines. And in 2018, ASRA updated their guidelines and really let us individualize our care. So this is from their app. So the advice now is that we make our decision, we individualize it. There's concierge medicine again, based on the site compressibility, vascularity, and the consequences of bleeding if it occurs. And so that's really helped us at Harborview. We've really been able to relax our restrictions on peripheral blocks that we had before, and it's helped with these arguments we have over, we were asking our surgeons to stop giving twice daily enoxaparin because we were worried about bleeding and our guidelines, and they were worried about DVTs and PEs. So we've worked really collaboratively. We've got this ongoing QI project to monitor for complications of bleeding. and that's opened up lots of doors for peripheral nerve blocks. So when the surgeons express their concerns to us, their deepest concerns, it's usually compartment syndrome, motor block, rebound pain. And we've spent a lot of time going to their meetings, talking to them about their concerns. And really, I find my take-home message is always that this belief that we're either going to block a patient or we're not going to block a patient, this binary thing. And the thrust of our education is trying to explain that there's so much more to it than that. So we have a choice. We have peripheral nerve catheters or single shots. We have, do we add a patient-controlled peripheral nerve catheter? We give them a button to press, which means that they probably use overall less local and they have less motor block. For plain blocks, we can give pushes, intermittent pushes of local anesthetic, which means that we spread in that plane, and again, overall use less local anesthetic. We can use different strengths and concentrations of local. We can add drugs to make it last longer. So with those discussions, I think our surgeons are beginning to realize that we can individualize this stuff. We can provide that concierge service. And when I think about our day-to-day now of being on the block service, we make a lot of decisions about every block, trying to get it right every time. So the timing, do we do it pre-op, which is our preference, but sometimes burn surgeons don't know where they're going to take graft from, or our trauma surgeons are worried about nerve injury and they want to have a look first. The choice of single shot, catheter, what kind of catheter we use, what drugs we use, how long do we want it to last, do we add dexmedetomidine, dexamethasone, epinephrine, the pumps we use for continuous blocks. So as I mentioned before, we can set them to give boluses every hour. So push so that they spread in this plane, or they can just trickle local in continuously over an hour. We can add a button for the patient to control, which gives them this sense of control, which seems to help, but also overall seems to be that they use less local and get less side effects like motor block. And then we're now sending patients home with catheters routinely. And so we have these discussions about how long you're going to have it in. The military experience is that patients can have catheters for weeks and weeks and don't really have problems. We're not quite there yet, which is mainly an expense thing. But the timing of when we take it out and when these patients make it home is important. So practical limitations. As we get more specialized, we run into these limitations of what we can do. So we're limited by personnel. We only have a 5-day-a-week daytime service on the block team in my hospital. We need nursing care on the floor who are trained to recognize complications. We need the time and the communication with the surgeons to place them, dealing with patient expectations and fail blocks and complications, and all of that stuff needs institutional buy-in and resources. As we've started to build our ideal block service, we've looked at the equipment we have, the space we need, the staff we need. We've really tried to look at our relationship with the surgeons and listen to their concerns and try and address those individually, and qualify that with good QI data to say that we're doing a good job. We're beginning to follow up patients more robustly, including the patients who could have got a block and don't get a block, so we can compare those complications to, we can follow those patients up long-term as well and look at long-term complications. So I alluded to this with marginal gains, but no one said it better than this famous French chef. So, and I think cooking's a lot like anesthesia. So we do a lot of little things well. We have good people, good equipment, and good knowledge and skills, and that's how we get things done well. Thank you. Any questions?
Thank you, Paul. What I will do is ask you to stop screen sharing and then invite all of the 3 panelists that we've just heard from, Arman, Itai, and yourself, Paul, to answer our questions. So, Itai, I'm going to start with you. One question that was posted was, how do you evaluate the microvascular blood flow?
So the answer is I don't. There are 3 classical ways of evaluating it. One is video microscopy, the other one is laser Doppler, and the third one is laser speckle. They're a little different in the ability to measure different depth and different things. But the fact of the matter is that clinically, really only people in the ICU have evaluated it. I think there was a consensus that is statement, a roundtable from 2007, even how to classify the data, because at the end of the day, you get the data, how do you classify it so you can move forward? And even that has not been completely done. So there are ways to do it, but really the people from critical care have been leading this field, and I don't think we have been able to bring it into the OR very effectively.
Thank you. Any comments on that? No? No. Okay. So another question for you, Itai, as we got you on the spot here. Do you admit all of your elderly trauma patients who are post-op to the ICU? No. It's, I think, although about 30% of the hospital beds and at Harborview are ICU beds, that's completely impossible, even for us. Okay. Arman, there's a few questions, one from Musab Jamal. Can hypertonic saline be administered in polytrauma patients with multiple comorbidities?
Yes, I mean, we use it. Again, the emphasis here is to, first of all, there's not good data out there, which agent to choose. We need robust data. And we need all of you to start developing interest to get those sort of multi-center trials going, to find out which agent is superior. It's hard to conduct these trials. Second, that institutional familiarity is important. You know, you can't use, if you don't have proper education and training and understanding around these agents, it's hard to safely administer them. So it's important to get familiarized with them. For, you know, in terms of reducing brain bulk, both agents are effective. We don't know their long-term outcome effects. So most of the time, what we observe and do is patient arrives from the ED, and first bag we grab is the mannitol at this moment. And then once we start doing our osmolarity and sodium checks, we move towards the hypertonic saline. And especially if the patient is hypotensive with low volume, hypertonic saline appears to be on the studies more effective and safer to use.
Thank you. Paul, one for you. I'm glad to hear you've still got your accent, by the way, despite living and moving to Vienna. And that's regarding the retrolaminar block. Are there any specific contraindications for this type of block that are different from a standard epidural, for example?
It's a pretty forgiving block. You are close to that spinal column. You're going down onto the lamina, so fractures of that spinal column in that area will be a relative contraindication, and then all the other contraindications of local generally. So overlying trauma, skin, cellulitis, things like that. But no, I think all these trunk blocks tend to be fairly forgiving of the usual contraindications that we see in neuraxial blocks. We're not going near a nerve, we're in a pretty open space. If there's a bit of bleeding, it's usually not a problem.
Thank you. Another question for you, Paul. With regard to your blocks for these trauma patients, are you preferring not to give them to patients, for example, if they have a bacteremia, or are you still offering these patients blocks?
That's a good question. I think that kind of comes down to the individual regional person and their level of comfort. There's no evidence that a bacteremia will be a problem in a single shot block because the needle's in and out. Seeding of a catheter is likely to take place fairly quickly, just like with a central line. So I think when that's the option, it's really just an individualized risk-benefit discussion. What are we achieving? You know, are the markers of bacteremia trending up or down? And where are we going to place that catheter, and what are the consequences of a potential abscess in that region? But again, it's a lot more forgiving than and less scary than an epidural would be.
Thank you. Arman, somebody, actually Veron Yala asked, based on your experience, which fluid do you prefer to use? You may have already answered that, but I'm just...
I did answer it, but again, you know,
Yeah, isn't it?
for polytrauma patients coming with hypotension and major bleed, probably I will pick up the hypertonic saline as a first agent, as far as the evidence tells us so far.
So Paul, Harborview has an interesting way of providing post-operative lower limb blocks, which many people won't necessarily be aware of. Would you be able to share with us how that service is provided and how you do it?
Jeff, this is why you need to come back to us. We've slowly changed hearts and minds on that. When I came 5 years ago, or came back 5 years ago, yes, you're right. We were doing most of our blocks post-operatively. We had this, frankly, slightly crazy system of taking patients out intubated on a propofol infusion and performing blocks in the PACU. And the reason for that was largely convenience, turnover times, worries from the surgeons about having a catheter in the field and wanting to assess a compartment or a nerve before. So some valid concerns, but we found it was just blocking our PACU. Patients weren't doing as well. Those things I talked about, those sensitizations, they occur during surgery. And I think we saw some evidence that patients just didn't get as good pain relief when you were doing the block post-op. COVID really helped us. We managed to say that we're no longer going to extubate these patients in PACU because we're worried about aerosolization. So we really took that and ran with it and really pushed to do pre-op blocks. And we've just stuck with that. And now our surgeons are accepting that a lot more. They see that we're not really getting in the field and it's not a big problem. And other centers are doing it. And we're not bunging up PACU with all these patients. So I think there's been a lot of benefit from that in the last year or two.
Thank you.
Jeff, so I just want to comment. So I think like anything else, you know, when we're partnering with different specialties and teams, the intensive communication and dedicated person who leads those communications is important. You know, like Paul, we put a handsome guy to make that communication with our surgical colleagues, and he's persistent. He goes around and attend to those meetings to convince them. And another thing is long-term follow-up of these patients are important. You know, we used to hear that surgeon telling us, you do this block and you never see the patient again. And they come back with complication and so on, and we can't find you. You know, now we have this dedicated people who can be approached, and then they also do the follow-ups. That helps to build that confidence in our services.
Yeah.
Sorry, Paul, what were you going to say?
No, no, thanks. I was actually just going to make the comment that even though we were doing these post-op blocks and they were, you know, just not something that most of the rest of the world does, I do have to say we didn't see many complications from it long term, and it was just a comment. I was surprised about that, but I think overall doing them preoperatively has really helped with the way patients wake up, and certainly our PACU nurses noticed the difference in how well the patients wake up now. So I would recommend if you're building a regional service to push for doing them preoperatively and getting them in place.
Thank you. There doesn't seem to be any other questions that have been presented or posted on the Q&A session or even the chat. So I will just open this as a last opportunity for someone to post something or raise your hand, and I will ask you a question for you.
Jeff, can I just, Albert asked a quick question whether we have a Jerry team to see this thing.
Yes.
And if I can share my screen quickly, I want to show you something that I think really ties well to what Paul and Armand have said. So regarding the straightforward question, we have a problem trying to get, because who's the primary, who's the secondary, if it's orthopedics or it's geriatrics, et cetera, et cetera, et cetera. But I want to show you something that we have, that we have looked at a couple of years ago. I don't know, can you see this now?
Yeah.
Okay, what we actually asked is just to talk about people working together. Yes. So what we actually asked, and this is just internal data for Harborview, we took a bunch of anesthesiologists and people from geriatric and medicine and ED and et cetera, and we asked them, for patients who are getting to the OR, how well do you think we provide these interventions? And as you can see, a dot in each one of them is, for example, the dots are anesthesiologists. As you can see, we feel that fluid resuscitation is well done at about 20% of the patients. And if you look at emergency medicine, they think more like 70% of patients. And really, I think that Armand has been instrumental in getting this working, that we have a new service in the last 6 months that I can't say anything about because my wife is in charge of it. But what it really, one of the things that it tries to do is really to improve the communication between all the services before the patient gets to the operating room. And maybe Armand can say something about that.
Thank you, Itai. Yes, so I mean, everybody has their own opinions, and we need to work towards changing that opinion if we believe and science tells us to do so. And the data is important to prove our points. And for that reason, we have been extensively collecting data in our pathway care deliveries. So with that data and sitting with the surgeons and other administrative leaders, we're able to make that change and influence the future of care delivery. So that is really long and arduous work that we need to take, but it is working once you invest the time and effort.
Thank you, gentlemen. What I propose we do is thank you all for your contributions, your expert contributions, and we will take a 5-minute comfort break and restart at probably slightly after 11:30, just to give people that opportunity to recharge their coffee glasses. Thank you all. We will continue.
Keep safe. Bye-bye.
Bye.
Testing, testing, 1, 2, 3, testing.
I can hear you, Avery.
Great.
You should have access to screen share.
Okay, I'm just going to be back in 3 seconds.
No worries. Okay, ladies and gentlemen, it gives me great pleasure to open the third and final Charlie session of our conference this morning and introduce Dr. Avery Tung, who is a professor in anesthesia and critical care here at the University of Chicago. He is also our quality chief for anesthesia. Avery, I'll hand it over to you, sir.
Okay, does that look right? Just real quick.
Yes.
Okay, very good. All right, good morning, everyone. I'm Avery Tung. I'm a critical care and cardiac anesthesiologist at the University of Chicago, and also critical care section editor for ANA, and I'm going to talk about the proper trial, one of my favorite subjects. I am the section editor. I'm paid to be skeptical about what I read. I find proper a very tremendously entertaining example of, sort of how studies can look like one thing to one person and another thing to another person. I am the quality chief for our department, so I spend a fair amount of time arguing best practice with people outside our department and inside. And I am not a traumatologist, so please don't yell at me. I mostly transfuse bleeding, burning cardiac patients. And what I bring to this talk is an observations as an editor, and I'll get to that in a second. 5 things in this talk we'll get through in the next 30 minutes. Hopefully, we'll talk a little bit about a history of proper, and why we had to actually do that trial. We'll talk about what you see in proper is what you want to see. We'll say that it's unlikely ever to happen again. And I'll observe why I think that is. The great mystery of proper, every single journal club I have done with this paper in the last 5 years has boiled down to the same interesting question about the platelets, and I'll talk about what I think is going on there, and finally back to whole blood. Now, the clinical question that proper was designed to answer was this one. And so here you have, let me turn on my pointer here, you have your surgeon, and your anesthesiologist and the medical student who's completely bewildered. And the surgeon is where you're resuscitating, the patient has multiple penetrating injuries. The surgeon says, how much? You say 8, 4, and 4, and she says, no, you need to give more FFP because the patient's bleeding, and here we have the trauma fellow standing in the blood, which is typical for these penetrating traumas that we see. Now, I personally would agree with the surgeon, although I have not resuscitated trauma patients commonly, in my youth, I was a burn intensivist and burn anesthesiologist and spent many, many hours resuscitating patients whose burn wounds could not be tourniqueted off to protect the bleeding, such as the torso and the head, and we empirically very quickly came to the observation that rather than giving crystalloid or albumin, that it was better to accompany the blood with the FFP. And so we evolved to the one-to-one strategy as the easiest way to implement something that would not make patients bleed as we were trying to resuscitate them as they were bleeding. So it was with some surprise that this came into my mailbox, and this was in Friday in 2015, and this was a paper that came to the critical care section of ANA. Back then there was no trauma section of ANA, so it came to me, and it was titled, "What is the proper transfusion strategy in trauma resuscitation?" And I said, oh, that's interesting. Proper wasn't published in ANA. Why are they using our journal to observe about another paper published elsewhere? And the tagline of this paper was, "We believe a critical examination of the methodology necessitates cautious interpretation of the results," and that's always true. We actually ended up publishing that paper, and for those interested, the citation is here. We actually slapped a CME label on it here. And I'll make a third observation, which is that the authors of this study, were not novices in massive blood transfusion. Everybody knows Ari Shander is the ASA liaison to the blood bank, Dr. Smith, noted trauma anesthesiologist, Greg Janelle, probably the junior member of this group, and Dr. Shore Lesserson and Levy, obviously no strangers to giving blood to patients who are bleeding. So it was an interesting observation, and in working through the paper, bringing it from submission to publication, you realize that there's been sort of a sea change in how people think about why bleeding happens in big trauma, and it comes all the way from the early studies of platelet deficiency as the most common reason why people who bleed. This is what they taught me when I was a resident, to the introduction of FFP somewhere in the mid-1980s and the observation that we should only give that in patients who you have known factor deficiencies. And then right here it says, well, if we're not going to give platelets or FFP, we should just give crystalloid because studies show that giving crystalloid is the best. And there are still every now and then residents who come through who tell me that in their medical school they were taught the first thing you do in big trauma is give 2 liters of crystalloid and then stop and see if they're still bleeding. And it wasn't really until 2007, I actually think this is sort of the earliest sort of thought that maybe the best fluid to accompany red cell units was not crystalloid, but maybe it was FFP for patients who were big bleeding. And this was in 2007. Many authors here well known to everybody who's on this call. And the mid-2000s were filled, I would say, with studies of this type. Retrospective examinations of red cell FFP ratios, all finding the same observation that the tighter the ratio, the better the survival. And the only question or difference in many of these trials is whether you order your graphic going down like this or going up like that, because they all showed the same thing. The tighter the ratio, the better the outcome. But because all of these were retrospective, the question was, was there selection bias? Was there survival bias? And that meant that we had to do this trial. And this is the proper trial. I've shown it to you here. I've given you the PubMed ID. If you haven't taken a moment to look at it, pragmatic multi-center 1:1:1 versus 1:1:2. Everybody knows this trial, so I'm just going to go quickly. The primary outcome was 24-hour and 30-day mortality, which when you think about all the things that happen to trauma patients, is kind of like a home run. I mean, you're really swinging for the fences. Secondary outcomes are things you might imagine you would look at in a trial of what you do in the OR. And the patient population was typical trauma, 54% blunt, and only half of them had more than 10 units of product altogether. The finding, everybody understands, the conclusion of the proper trial was that the 1:1:1 did not result in significant differences in mortality at 24 hours or 30 days versus patients who got 1:1:2. And that was true across the board. It wasn't just 24 or 30-day mortality. It was time to hemostasis, total blood products, 30-day disposition, and 23 pre-specified complications, including TRALI, SIRS, AKI, infection, and DVT. The plain English conclusion right here from the first paragraph of the conclusion section of the JAMA article did not result in significant differences in 24 hours to 30 days. But as you can see from the PubMed citation, proper was a very controversial trial, and whenever you see a bunch of comments afterwards, that people are either arguing about or disagreeing with what their proper trial found, and if you're an editor, sometimes you like this if you're trying to sort of, put a question or comment out there, but if you're sort of worried about whether people are, not liking what, you put out there because they don't like the reproducibility, then you feel like it's a bad thing. I just want to highlight, that when you start sort of complaining about the trial in journals other than where the journal was originally published, you have a controversy that is swarming. Now, if you read all of those, what you end up with is the question of what you see in this picture. And what you see in this picture really reinforces your prior beliefs. The gray bar, the 1:1:2, higher mortality at 24 hours and at 30 days than the blue bar, unless you count the error bars, in which case you find no difference. Because these error bars overlapped, the official conclusion of the trial was that there was no difference in mortality. But as you lean back and as you squint, and the thing that I hear most often is people say, okay, Avery, fine. You say there's no difference in mortality, but which group would you rather be in? And when you say that, well, I don't know, I guess the blue bar here does look like it's lower than the red lines and then the gray lines, so maybe I want to be in the blue line. But in truth, there was no statistical difference between these two outcomes in the trial. Now, I will observe, for those who are about to jump all over me, is that there were two secondary outcomes, hypothesis generating only, that there were fewer deaths within 24 hours from exsanguination in the 1:1:1 group, with a 0.03 p-value, and more anatomic hemostasis in the 1:1:1 group. And this was defined by the surgeon who, by the time they got this, was unblinded to which group the patient was in. So you can argue whether this finding is sort of biased by what the surgeon thought the patient was getting, what the surgeons thought that the patient should have gotten, and so on. But nevertheless, there were positive outcomes. And the Janelle paper, sort of made several comments that I've sort of, given you the statement, I've given you the theory, and I've given you sort of the, the comment from the editor that's skeptical, which is me. 1:1:1 platelets got the patients got platelets with the first 6 units, but the control group did not. And they say, so maybe the effect was with the early platelets. But I'm here to say what effect? It was a negative trial. There was no effect. There was no effect. 1:1:2 platelets got more cryo, despite no lab abnormalities. So maybe the 1:1 patients secretly did better, but you just can't see it because the 1:1:2 patients got more cryo. The 1:1:2 patients got less overall products. So was the 1:1 really more effective? It wasn't more effective. There was no difference. The proper trial is officially negative. And no mechanism, trauma-induced mechanism for what? The trial found no difference and thus was mechanistically agnostic. You can't argue a mechanism for something that doesn't have a difference. And it's not just Janelle at all. It's not just Shor Lesterson and Shander. It was also everybody on Twitter, which I think is where you need to go to find out what people are secretly thinking about a trial, because they're not going to publish it because it has to get through peer review. What they say is that 1:1:1 was better. If you're going to read one paper from 2015, that's it. Traumasaurus Rex says better. See, this sort of carrot arrow sign says 1:1:1 is better than 1:1:2. Dallas EM says the same thing. Negative studies, but secondary outcomes support a trend towards mortality benefit. There's no trend unless you have a series over time. There's just an observation. Is that a trend? You tell me. And Wayne says here, hemorrhagic death less in trauma patients infused with 1:1 ratio. You look at those who tweet in languages other than English, and you get the same observation. I can't really sort of read the Dutch here, but I think they're saying that, that the 1:1:1 is better. Alberto definitely is saying, because he's got the mejor word here, that 1:1:1 is better than 1:1:2. Bad EM Africa says, better, and so does Michael from Adelaide. He's saying, well, it looks like it's better also. So you could be puzzled at why people see a positive result in proper, even though there's no positive result. This is my favorite one. These two here, they're actually sort of the prior Twitter is talking about this New England Journal trial for reversal of dabigatran, and they're complaining about how it's all industry driven. And so he said, well, you want to know a trial that really is worth it? He says, proper. That changed my practice, and Dr. Cotton agrees. But what practice? How does a negative trial change practice? It's negative unless you stop doing the thing because it's more expensive and it doesn't make any difference. So very, very interesting, and I'll say that, in lesson 1, we're unlikely to see another trial like proper again, in part because they had to waive consent, and that's increasingly used in critical care trials, but not necessarily sort of a thing that is easy to get through. In fact, we just got stuffed in our attempt to look at midazolam use in the cardiac surgery world and post-out 1 delirium because they wanted to waive consent in the multi-center trial, and we couldn't get authorization in our hospital to do that. In fact, you had to sort of trumpet your intentions to waive consent all over the place. This was the closest proper trial site to the Chicago. This was in the Medical College of Wisconsin, and they put something on their website. They said, if you want more information, visit the site. In fact, we can give you an opt-out bracelet. So if you get into trauma and you are unable to say that you want to opt out of the trial, you can wear a bracelet saying you want to opt out. And I've actually tried to get a bracelet, from, back then, but nobody still has one anymore. Maybe because nobody actually watches the website and knows that they were going to be non-randomized into a trial. Moreover, the second observation is, in addition to being waiving consent, proper was 4 times too small for the result that they found. Everybody knows that the observed mortality in the control group was lower than expected. I'll get to that in a second. And in order to see the difference that you really wanted to see, you would have had to quadruple your proper size. And I'm sure people on this call, are more versed than me in how much proper costs to do. Sort of blasting all over the airwaves that you're going to not randomize consent, staging a multi-center trial, arranging for all the blood to be available. I imagine well over $10 million. And if you multiply that by 4, that is a large amount of money you're going to spend to redo a trial, with the appropriate sample size to show the difference that you were going to show. Now, as it turns out, if proper is all we have, then that's good for the people who see a difference in their Rorschach blot. because it's a feature, not a bug for those people. They can make the following argument. They can say, okay, look, it was powered to detect a large difference in 24-hour mortality and 30-day mortality, but they actually got much smaller differences. So you could argue it would have been positive had we done all 2,000 cases. We would have had a result. We just couldn't do that. But that doesn't matter because it's all okay. We have what we have. We know what we know. The graph is what the graph is. You just have to go with the idea that had we actually just run the trial out to 2,000 patients, we would have seen a difference. And Twitter is full of the underpowered but argument. And here's Dr. Brohi, from the United Kingdom, I believe, a trauma surgeon, ultimately underpowered, but actually. And he shows the trial when you say, well, which group would you rather be in? And Dr. Tehan here, despite being underpowered, consensus appears that improved mortality. And that's, in my read of Twitter, is definitely the Twitter consensus. Proper was a positive trial, finding benefit to 1:1:1. The overlapping error bounds prevent you from concluding it, but had we just run the trial out to 2,000, we would have seen it, and now, we're good. We know what we know. Now, I'll say in the critical care world, we have seen several trials like this since Proper. Andromeda shock comparing capillary refill to lactate measurement for septic shock, finding no difference, but everybody thinks that, capillary refill was better. And bag mask, published in the New England Journal just 2 years ago, bag mask looked at whether you should bag mask the patient between induction and intubation in the ICU. Bag mask found greater desaturations in the patients who did not get bag mask ventilation, which is sort of obvious, but it's being marketed as a trial showing no increase in aspiration from bag mask ventilation, thus arguing that's okay to bag mask these people even if they have a full stomach. Ultimately, any rational person would have to look at Proper and say, we just don't need to know it this badly. That was worth another $40 million. Let's say the real mortality difference requires a trial that's 4 times the size. It's likely to cost a tremendous amount. And even if you drill down on a ratio of 1.86 to 1 or something, is that really the number one concern in trauma resuscitation? And could you spend that $40 million a different way? And of course, if everybody already has an opinion, which by now I'll tell you everybody does, you can't do the trial anyway, because where there is no equipoise, no believable trial result. And I'll show you this picture, and this is from the SOCA annual meeting in 2019 in Montreal. And we're all sitting in this room. And I was lucky enough to be at the podium to take a picture. And we asked them to say, how many of you have ever seen an ECMO save? That is to say, somebody that would have died if not for ECMO. And you can see 3/4 of the people in the room are raising their hand. Arya Shender back here, he would have raised his hand had he been paying attention. And I know that Michael Haney here from Sweden has seen one. He just didn't want to raise his hand. So there's actually more people raising than actually you would see here. And where there's no equipoise, you see that a trial doesn't change practice, because everybody thinks, well, I already know what I'm going to do, and this trial doesn't change my mind anyway. So I'll read it, I'll criticize it, I'll journal club it, but it's not going to change what I actually do. The same pattern, this is the Eolia trial, the same pattern. You see, here's a trial, here are the lines. The ECMO group looks like they did better, but the p-value is 0.06. And then there's a tremendous amount of commentary over whether it's really true or not, even including papers that are not the paper it was originally published in. It's all over, it's the same pattern. Over and over, we start to see this in trials that, quote unquote, are underpowered, but would have shown a difference had we just been able to get out to the right end. I like this. This is sort of the most entertaining comment I've seen on Twitter for one of these trials, because I like to follow the trial that is negative but everybody thinks is positive, because I collect them as a sort of curio series. And this is like the most positive negative trial ever. I like that. Lesson 2. Why did they do that with the playlist? Everybody who studied the Proper trial, everybody who's journal clubbed it, ends up at the same place. They say the group 1, that 1:1:1 people, they got playlists in the first box. But the 1:1:2 patients didn't get playlists until the second box. So there was an asymmetry in where you put the playlist. They could have put it in the first box. They chose not to. And the question is, why did they do that? Why are you almost intentionally kneecapping the control group by delaying the platelet administration to the second box? Now, you can't say they didn't know, because they know. And I'll get to that in a second. The great mystery of Proper is why platelets weren't in the first cooler. You can see it was thus possible to give 9 units before you got to your first platelets. Since the only positive findings were early intraoperative hemostasis and death-threatening sanguination, the agent of victory might have been earlier platelets. In fact, if you sort of blow this up big time, you can see here's the graphic. I've blown it up all the way to 24-hour. In the first 3 hours, there's actually a small dip in mortality, and maybe that's because they got more platelets. Why would they kneecap their study like that? Because they're just giving you a chance to criticize. Any skeptic out there was going to say, well, The difference is platelets, as Janelle et al. Sort of also commented in the ANA article we published. It's not because they didn't know. Prior to the publication of Chopper, there were numerous sort of retrospective trials finding that just like with FFP and red cells, that a higher ratio of platelets also led to better outcomes retrospectively. Whether that was selection bias or not, you can't say because it's retrospective, but they knew before they designed Proper that the platelets might have made a difference. The answer lies in the PROMET trial, and I'll show it to you first before I'll try to tell you why I think I know the answer, because it comes from the words of Holcomb himself. This is from JAMA in 2013, and this is sort of the observational trial that Holcomb did in order to frame the ratios of FFP to red cells. He was best able to test in the Proper trial that he eventually published, and buried in here is a mediation on platelets where Holcomb observes, he says, something, we found that although the people who died of bleeding, they died within 3 hours, by that time, only half of them had actually gotten any platelets at all. In fact, in the 30 minutes, nobody got platelets. So both groups in Proper received platelets earlier than standard care, because in Proper, you would get it in the first 30 minutes. And so I finally found a podcast here from the Emergency Medicine podcast, and I've given you the citation so you can it's still up on the web, I think as late as last month. And they asked Hogan, they said, why did you put the platelets in the second group? And he said, well, it goes back to PROMET. What we showed is that platelets were given late, if at all. In PROMET, patients were given after the median time of hemorrhagic death, which is what he showed. He said when we counted it up, it was after they'd already given 13 units of red cells. So we all felt very comfortable and proper that even if you put it in the second box, it was still going to be better than what they did in PROMET. So you see what Holcomb was doing is setting up a secret comparison between the PROMET result, and thus what he expected to see, and early platelets. And so I guess the interview says, so you are actually, that was part of your Proper design. You said, yeah, we planned that on purpose. You see, it's very, very smart. You see, both arms of Proper involved earlier platelets use than in PROMET. So Holcomb could say, I'm not just going to compare FFP to red cells, I'm actually going to compare platelets to earlier studies. And in fact, Proper found a lower than expected mortality in the control group, even though they had platelets in the second box. So a stealth result of Proper, very, very, cleverly, at least he said it on the podcast, you can listen to it yourself, is that the control group, even though it was in the second box, was superior to the PROMET baseline, suggesting that early platelets really do matter. In fact, this is the one of these sort of spin-off trials from the Proper study. This is in Blood Advances in 2018. I'm wondering why it made it only to Blood Advances, but you can see that the patients who got the platelets had sort of a lower incidence of death here, at hours and also days when compared to platelets for patients who didn't get platelets. Let me now finish in the last 8 minutes to talk a little bit about whole blood, which is another name for 1-to-1-to-1. Whole blood has kind of a spotty history. When you go back to the literature and ask, does whole blood work better than component transfusion for patients who are bleeding? At least as of 2004, the answer was, well, in this study of open heart surgery in children, the answer was yes. Is this study of open heart surgery in children? The answer was no. And so it depends on sort of which study and whether there's a time bias, and at least as of 2004, there wasn't clearly an observation. Retrospectively looked, in trauma patients, you can see that there was maybe no difference. I guess you could sort of interpret the observations here that whether you gave whole blood or component therapy in severely injured patients requiring large volume transfusions, they said, well, 24 and 30-day mortality is similar between groups, so not exactly clear. Whole blood has many concerns that I'm not going to sort of spend time going over this slide, except to observe that, the decision of when to transfuse platelets along with the whole blood is kind of a thing, because platelets deteriorate over time. You can't freeze the whole blood, so you have to keep it at 4 degrees. How exactly do you manage that? More recent literature, in trauma patients suggests that there may be some positive outcome from civilians, who are trauma patients who get whole blood. This is low titer whole blood. And you can see, they say, well, unlikely to harm. There may be a trend in lactated mortality in head trauma patients, but at least if you take the literature as a whole, it's my editor read, that the signal is not massive if there is a signal when you compare LTOWB versus component therapy. Even though you feel like whole blood is better, and having been old enough to use whole blood in my sort of resident days, I can tell you it certainly feels like it makes a huge difference when compared to component therapy, but maybe not if you're disciplined 1-to-1. A few other proper observations. I'm just going to run through this real quickly, and these references are all here if you want them. You know that when you compare Group A to Group AB plasma, you can use Group A in most patients, even though Group AB is optimal because these patients are least likely to trigger an immune reaction. You can use this kind of donor as well. It appears that there are cost-effectiveness studies suggesting that 1:1:1 costs more because you're transfusing more FFP, but you know the improved outcomes offset that cost. It may predispose to DVT formation. That's this one here, because I know people are going to yell at me for this one, but it's possible that it could. You know, it makes sense sort of when you think about it mechanistically. Older blood, greater mortality, but only if you transfuse a lot of it, you know, and tranexamic acid appears to improve 6-hour survival, but not 12, 24, or 30-day survival. And that's this paper all the way down here at the bottom. So to summarize, PROPER is the end result of a revolution in hemostatic resuscitation that started with platelets, worked its way through crystalloid, and ended up at FFP as the best solution to accompany red cells if you're going to transfuse. A state-of-the-art, meticulously designed and executed, very expensive, consent waived, you know, randomized multi-center trial, which found no difference in 24 or 30-day mortality. It's invited considerable scrutiny. People argue about it today. It's already 5 years later. Many disagree with the published finding that there is no difference between the two groups in terms of 24 or 30-day mortality. I feel like it's a Rorschach test for your prior beliefs. You know, if you're a blood banker seeking to conserve your FFP, you're going to argue 1:1:2 is just as good. In fact, our anesthesia group and our blood bank has had that argument already. We've said, you know, well, 1:1:1 is better. Say, no, it's not. You know, the PROPER trial found no difference. I used the PROPER trial to go back to the blood bank and say that the best traumatologist in the country can only predict transfusion greater than 10 units with a 50% accuracy. How can you yell at me for not using our entire MTP? Because we're arguably, you know, certainly not, you know, in the group of very, very experienced traumatologists yet. We'll not see another trial like it again because of cost and loss of equipoise. The great platelet mystery may have an answer in accidental comments by Dr. Holcomb on podcasts, you know, in the EM critical care section of the world. And back to whole blood, not obviously better yet, but accumulating studies. We ourselves are using whole blood here in selected patients. Our trauma surgeons have that choice to give it to them, you know, and we haven't seen big hemorrhagic or immune complications yet. Thank you very much.
Avery, thank you for a genius presentation. Remind me next time to allow you more time to speak so you don't have to speak so quickly, but that was awesome. Thank you, sir. So I'm going to ask you to stop screen sharing, Avery, and I'm going to then introduce our next speaker, and that's Dr. Keith Ruskin, who's a professor here at the University of Chicago. He's a neuroanesthesiologist and a budding astronaut. So Keith, over to you, sir. You're muted. You're still muted.
There we go. I'm good now. Okay. So Jeff, Peter, thank you very much for inviting me to participate. What I'm going to be talking about right now is largely theoretical. We have not yet had any traumatic events during spaceflight, but as we move more towards commercial spaceflight, more people go to space, and particularly more people whose main qualifications are being able to spend a lot of money to go, this is potentially a problem. And also as we move towards exploration class missions to the moon and to Mars, we could also see a traumatic event during spaceflight. So that's what I'll be talking about today. I'll talk about the physiologic changes that occur in an unusual environment, and I'll include isolation, microgravity. And that, I think, is the fundamental part of this talk. What I'm talking about is theoretical and built upon what we know about the physiology. And then lastly, I'll talk about some potential options for surgery or avoiding surgery during spaceflight using a couple of scenarios. So no financial disclosures. I do receive money from an FAA cooperative research agreement in which we're studying alarms, alerts, and warnings in air traffic control. I promise not to talk about air traffic control during this talk. Before I go too far, I'd like to give a shout out to one of the earliest physicians, was an anesthesiologist. Cloyd Green was a Canadian anesthesiologist, did his residency at University of Iowa, and then would ultimately go back to work after his career in space to Newfoundland. But after becoming a physician in charge of a bomber wing immediately after World War II, he began to do research on the effects of high altitude on pilots. and was recruited to Brooks Air Force Base, where he did some of the earliest space flights sending rhesus monkeys into orbit. So here you can see a picture of him getting a rhesus monkey into a combination restraint and chair so that they could send that monkey to space and then see what happened to him when he came back. So when are we likely to require surgery during spaceflight? Either during trauma, and the most likely etiologies are going to be crush or penetrating injuries, potentially orthopedic injuries if we're on the moon or Mars, non-traumatic surgical emergencies, and this is of particular interest because we will never find out exactly what happened. But so far, there have been 2 possible cases of appendicitis that may or may not have occurred in Russian cosmonauts who then had to come back to Earth a little sooner than planned. And theoretically, there is a risk of intracranial pathology, and we'll talk about why as we go through some of the physiology. I'll start with just a hypothetical case to focus us. We have a 34-year-old woman who's an astronaut. She's doing an EVA on a lunar exploration mission, and as she's working, she avulses her ankle. So the question is, do you manage this on site, or do you return to Earth? Do you perform surgical management versus conservative management? Just try and stabilize it there. And lastly, what are the techniques that you're going to use to solve this problem? So here's an example. This is a prototype. This is a prototype design of a lunar habitat for, again, an exploration mission. And you have a couple of problems. Firstly, you have issues with communication. Now, if you're on the International Space Station and you need help with a medical issue, you have near instantaneous communication to Earth. Similar with the moon, there's about a 1 to 2 second round trip communication delay, but it's pretty quick. You can have a real-time conversation and get guidance to solve a problem. If you're going to Mars, once you're on Mars, the round trip communication delay is 40 minutes. So there's no way to get real-time guidance. And in fact, this has been simulated with some of the Mars analog missions, but essentially the crew is autonomous. Again, same thing coming back to Earth. You can get back to Earth in a true emergency from the International Space Station in a matter of hours. And in fact, this has nearly happened once. There was a fairly large meteorite that was going to come within, I believe, a kilometer of the space station. And what they did is during the time that it was going to pass, they actually evacuated all the astronauts into the Soyuz capsules that are kept there as lifeboats, and they just sealed themselves off from the space station and waited. When the meteorite passed by, they went back in. But the plan would have been, had the meteorite hit and destroyed the space station, just to separate the Soyuz capsules, return to Earth. If you're on the moon, the closest analogy to that is wintering over in Antarctica. Typically, it'll take you 2 to 3 days to get back to Earth. But at the same time, it's extremely expensive. Coming back from a lunar mission could cost billions of dollars in terms of lost opportunity, disruption of the mission, getting you back in time. Now, Mars is a completely different story because once you're in a Hohmann transfer orbit on your way to Mars, you're going to Mars. There is no way to turn around and come back to Earth. And that round trip is anywhere between 18 and 24 months, depending upon the specific orbit that you're in. So let's talk about some of the physiology. This is a 747. I was flying NASA a while ago. Here's a slide that I use mostly to talk about physiology, but here I'm just going to use it to explain gravitational forces. Here's our fighter pilot, or plastic fighter pilot, sitting in his little plastic chair. This is an homage to Avery. It's not Lego, but it's the best I could do. If you're sitting in the chair and the airplane is going up, you're experiencing plus GZ forces and blood is pooling in your feet. If the airplane is going down, you're experiencing minus GZ forces and blood is going to your head. Back and forth. If you're in a car and you slam on the brakes, you're experiencing minus GX. And if you step on the gas and you push back in your seat, you're experiencing plus GX. So just keep those forces in mind as I move forward. As we talk about microgravity in space medicine, you have a number of physiologic effects. You have cardiovascular deconditioning. Astronauts that return to Earth after a stint on the space station typically need weeks of rehab to get back to where they were. You also have a unique entity called spaceflight-associated neuro-ophthalmologic syndrome. And that is, the cause of that is currently under investigation, but you get visual changes that occur typically after a few weeks to months in space and can last for months to indefinitely after you return. You have radiation exposure once you leave the protective magnetic field of the Earth. You have environmental toxins, and if you release something noxious into the atmosphere of your vehicle, you can't step outside for a breath of fresh air, obviously. Depending upon whether you're in the sun or you're in the shade, you can have hypothermia or hyperthermia. And lastly, you can experience hypobaric decompression sickness in the event of a sudden loss of pressure. So minus GZ, and an example of minus GZ is Felix Baumgartner's jump from the Red Bull, for Red Bull. He briefly held the record for the highest jump. Shortly thereafter, he was eclipsed by a Google executive who did his jump in complete secret. But what you can see is just because blood is no longer pooling in your legs, it's pooling up in your head. You can get bradycardia, junctional rhythms, you can get asystole. You get cephalad displacement. This is caused by cephalad displacement of the diaphragm and abdominal contents, causing vagal stimulation. You also get venous pooling and atelectasis in the lungs. You can see conjunctival hemorrhages, and that second reference, the one by Adler, she was the medical student. We actually described what happens when you're exposed to -8 GZ during aerobatic flight, and it's actually a fairly interesting discussion. You can also get cranial vessel engorgement and hemorrhage, and in fact, that's what happened to the person we discussed in that review article. He actually wound up getting a carotid artery dissection. When you're just in a microgravity environment, you still do get blood, a headward shift of blood. That can cause a baroreceptor response. You also get an endocrine response to that. You get increased pressures in your central compartments. You get renal fluid and salt wasting. People are worried about kidney stones because you lose calcium because of bone loss. We'll talk about that in a second. You get arrhythmias, and you get ventricular repolarization abnormalities. Now, most of the renal fluid and salt wasting and the dysrhythmias resolve in a matter of days. But long term, you do get cardiovascular deconditioning and orthostatic intolerance. And next time you look at astronauts on the space station, you'll see this is what we look like here on Earth. This is what the astronauts on the space station look like. They tend to get very puffy faces, and they tend to have chicken legs. And you can actually see that when they interview astronauts on the space station. You can sort of see that they look different than we do. When you get back on the ground, you get orthostatic intolerance because you can no longer pump blood up to your head. And the blood pressure in your feet is actually very high, but not quite as high as it is on the ground. But you do get blood pooling in your feet. Again, you just lose the ability to compensate for all this. Most of it comes back after a few weeks of rehab. In your brain, you see intracranial hypertension. You get an upward shift of all the brain structures. The ventricles are enlarged. And over time, you see decreased gray matter, especially in the temporal and frontal lobes. Space sickness is an entity where people just get nauseous the first few days in space. And that's caused by fluid shifts in the vestibular canals. Briefly to talk about spaceflight-associated neuro-ophthalmologic syndrome, you can either get unilateral or bilateral optic disc edema, flattening of the globe. You start to see choroidal and retinal folds. You also see refractive errors start to occur, so people need glasses once they get home. You see signs of infarcts of the nerve layers in the retina, specifically cotton wall spots. And again, nobody really knows why this happens. This is an open question in space medicine. During spaceflight, you can also see intra-abdominal changes. Intra-abdominal hypertension obviously is exacerbated by critical illness. And during spaceflight, you start to see some malperfusion of the gut. You see changes in the microbiome. All this can theoretically result in disruption of barrier functions, and this becomes much worse if you have some kind of critical event or intra-abdominal event during spaceflight. The microbiome is altered. Nobody understands quite why that happens or what that means, but it can potentially change your ability to respond to an intra-abdominal process. Typically what you see is the body tends to mitigate that. You actually start to build up your intra-abdominal, you start to like change your intra-abdominal wall so that you decrease that pressure effect over time in space. But it's something that, again, happens. We're not sure what the meaning of this is yet. Also, when you're in microgravity, you get on average a 5-centimeter increase in height. You get spinal pain and deconditioning. Low back pain is a significant problem in astronauts that are on orbit. And for obvious reasons, you can't take you can't take analgesics that affect your ability to perform on the mission. You also start to see paraspinal muscle atrophy, and that doesn't always come back. Typically after 6 weeks, you get a little bit, almost 70% of your paraspinal muscle is back, but not all of it comes back. You can also see injuries related to pressure suits, and this is a potential problem that could need surgical management during space flight. Because the suits tend to get stiff when they're pressurized, you tend to put more pressure and more torque on your joints. You may over-recruit muscles, and this has led to joint and tendon injuries in astronauts. You can see injuries caused by pressure sores if the pressure suit is pressing against a certain part of your body. You can see abrasions. In particular, shoulder injuries have been reported. Very common in astronauts on lengthy EVAs is fingernail delamination. They lose their fingernails, and it takes them a little while to come back. They get decreased blood flow in their fingers because the gloves are so stiff and restrictive. You can get, again, skin abrasions that could then potentially become infected. And you can see foot injuries if you're trying to fit your boot into a foothold while you're working on something outside the vehicle and you miss. Again, now you're in a stiff thing with limited range of motion. You twist your ankle, and there you go. So let's take a look at orthopedic surgery during spaceflight. This is a review from about 2 years ago in aerospace medicine and human performance. And the risk of fractures is probably low in microgravity unless you happen to shoot yourself across the vehicle, as astronauts tend to do. Mitigation strategies that are already in effect on the International Space Station is the advanced resisted exercise device, a treadmill, and cycle ergometers. And the idea is just to put stress on the bone and hopefully minimize bone loss. Bisphosphonates have shown to have an additive effect, again, to prevent bone loss and fractures. If fractures do occur, and we haven't had any happen yet, but initially the thought is if it's a non-displaced fracture, just to try low-intensity pulsed ultrasound and magnetic field therapy as just non-invasive therapies, intermittent doses of parathyroid hormone, and again, bisphosphonates. If a surgical intervention is needed and you can't get the person back to Earth, one recommendation would be a universal external fixator device that you just kind of put on, either that's completely external or that you can put on with just pins. And that leads us to the problem of training and skills. And if you have a truly autonomous crew, as you would if you're going to Mars, you can look at 3 levels. You have a core component, which is just basic resuscitation and primary trauma capacity, almost like EMS or ED physicians, but without any specialized equipment or skills. The next step is you have somebody who could treat most life-threatening conditions, and this would be a surgeon, an anesthesiologist, an emergency medicine physician working in a level 1 trauma center, and that might their skills might include the ability to do spinal anesthesia, some kinds of regional anesthesia, or general anesthesia with just something simple to use like ketamine. And procedures that you might be able to do with some basic training is laparotomies, amputation, and very simple kinds of orthopedic surgery. And again, this is to treat truly life-threatening conditions, not to treat something that would be better fixed after the person returned to Earth. And you need physician-level skills for this, probably surgical-level skills, some basic anesthesia skills, but not specialized anesthesia. And probably the best example of this was the physician who was wintering over in Antarctica a couple of years ago, who realized that she had a breast mass and removed it herself under local anesthesia because there was just no way to get her back. The weather was too bad. Lastly, you might have specialist level skills, and this is what you might need on an exploration class mission or colonization mission. And this is somebody who could provide true prolonged multi-organ support, somebody like Avery with critical care capabilities. So let's look at a terrestrial analogy of how impairment might work. This is an article that we published. It's actually published ahead of print. And the topic of the article was personal protective equipment in the context of COVID. But you can easily apply some of the lessons learned to working in a pressure suit in an austere environment. And if you think about what you have to do if you're taking care of somebody with COVID, you have an N95 mask with a face shield or a PAPR. You've got a gown, you've got gloves. If you're working in a trauma operating room or a burn operating room, it may be extremely hot. So you've got a whole series of physiological and psychological stressors, including decreased dexterity, increased work of breathing, overheating. You've got the fear of contracting COVID-19. Now, if you're on a space flight, you may have decreased dexterity. You're definitely in an austere environment. You may have increased, it may be harder to breathe, or you may be dealing with your own issues if say the injury were caused by damage to the vehicle. Instead of fear of contracting COVID-19, you may have fear of never coming home. And so there are a lot of analogies to operations in high altitude and hazardous environments. And in fact, most of my co-authors on this article were aerospace specialists. And the key thing to take away from all this is that your ability to perform tasks is impaired by all of this, and that impairment is additive. And there are a couple of very interesting studies looking at a so-called task-on-task model, where you break the required skills for any individual task down into their individual components. And in this particular example, we're using intubation in full PPE, and we're looking at cognitive performance. You need to be able to think your way through the skill. You need to be able to see, and that's impaired by the face shield. You need to have dexterity, which is impaired by the gloves and gown. And in this particular case, you have multiple layers of PPE that reduce performance. But if you look at the literature discussing this task-on-task model, you can mitigate the impairment in any one of these domains, you can significantly improve performance on the overall task. So we're out in space, we're in our autonomous environment. We only have what we brought with us. And one of the things we'll need are surgical instruments. And this is a lab on the International Space Station formed by a group called Made in Space. And it's 3D printing capability in space. So the idea behind this is that you could do, if you don't have the instruments you need, you can make them on site from pre-sent plans or plans that are sent to the vehicle from Earth. So here you can see they made a tool to manipulate certain bolts. I like that it's just floating there in front of the printer. One of these days, I hope to have something like that. This was actually studied during one of the longest and most detailed Mars analog mission, the Hawaii Space Exploration Analog and Simulation Mission, HI-SEAS 2. And what this group was asked to do at some point was to pretend that they had a surgical emergency, and I believe they had some animals that they could use, and they were told how to 3D print surgical instruments out of ABS plastic, and specifically they had a sponge stick, a towel clamp, a scalpel handle, and tooth forceps, and then they were given simulated surgical tasks. So these are 5 crew members that had no prior surgical experience at all. They were just told what to do step by step with a simulated 40-minute radio delay. And they were asked to prep and drape a surgical field, make an incision, then suture an organ that had been avulsed during a simulated trauma. And all the tasks were successfully completed, and there was no difference between using the 3D printed instruments, and they were also sent there with control instruments that they were told about, actual surgical instruments. So 3D printing surgical instruments may be a solution in an austere environment. How do you anesthetize a person having surgery? Regional anesthesia is one possible technique. Again, you have people that haven't been trained in how to do blocks, but this is something you can teach people on the fly. And here's an example of 2 astronauts on the space station doing ultrasound for a research project. The advantage of regional anesthesia, of course, there's less physiological impact, so you don't have to worry as much about the cardiovascular deconditioning. You can do them pretty much the same as you do them on Earth. The big difference is you have to secure both the patient and the proceduralist. And you can see here that our patient has his legs put in toe holds, and the surgeon's got his feet hooked around a toe hold there so that they don't go flying off. And if you can teach somebody how to use ultrasound or show them the images that they're looking for, they can probably use that to manage a wide variety of injuries. If you do have to do sedation, again, there's not a lot of work on this. Ketamine is one example that Jochen Hinkelbein's group talks about. This is my group. We published this article earlier actually late last year now, looking at moderate sedation for either procedural sedation or for shallow metabolic depression for long duration space flight. And what we recommended was intravenous dexmedetomidine. You get a little bit of analgesia to it that will work as an adjunct to whatever else you give. You have a cooperative patient, which may not be true with ketamine. You have no respiratory depression. After the person is recovered from dexmedetomidine, you don't have any degradation of the psychomotor vigilance test, which is a measure of a person's ability to think and perform certain specific tasks. And it may be associated with less postoperative cognitive dysfunction. And again, this is critically important on a mission, on a space mission, because after the person's recovered from their surgery, you may need them to perform tasks or to act as a functional crew member. But again, ketamine is also an option. Ketamine has been used as an anesthetic for surgical procedures. Again, another option that will need to be carried as we go on these exploration class missions. Practically, in addition to drugs and regional anesthesia, how are you going to manage the airway if you have to? Again, this is Jochen Hinkelbein's group. Airway management, supraglottic airways seem to have a very high success rate in microgravity. I've tried it. You can do it. You just have to hold the patient's head between your knees. Similarly, endotracheal intubation is the same thing. You have to restrain both the patient and operator, or when you put that laryngoscope in, you're going to go flying. Once the patient's airway is managed, there's no real difference in ventilation. A couple of the larger problems is that it is impossible to remove air from fluids in microgravity. So this will require that you package IV fluids specially and don't get air in them, because you can't de-air the fluids. Also, because there's no gravity, there is no way to get fluids to run by themselves. So you have to have infusion pumps and specialized administration sets that facilitate delivery of fluids without any risk of air. If you have to do ATLS, and we haven't gotten there yet, but I'm sure we will one day, some of the things you have to contend with are facial edema, which can complicate airway management. And again, you have the decision about a supraglottic airway versus an endotracheal tube. Supraglottic airways are easier to put in, particularly by people without training. Endotracheal tubes allow you to secure the airway. You can use ultrasound to diagnose things like tension pneumothorax and hemothoraces. What we don't really know yet is how microgravity affects bleeding, because there's no gradient for, you just have the intravascular pressure forcing blood out. We don't know what that does. Initial management of limb trauma is just tourniquets and hemostatic dressings, which can be a problem if the person is still in a pressure suit and you're dealing with trying to seal the hole in the pressure suit caused by potentially penetrating trauma. If you do have to do manage abdominal or intrathoracic bleeding, then the next question is, how do you do open surgery? And again, this has never been done before, but there have been some some experiments in simulated microgravity and on the International Space Station. You will again come back to having an autonomous crew, and you've got to make the instruments you need, which is going to take a while. You need to restrain everybody and everything so they don't float away. And again, not only do you have problems putting blood and fluids into the patient, blood and fluids that come out of the patient can potentially contaminate the environment and at best make it difficult for other people to function, at worst, potentially a transmissible disease. So one potential solution has been to put an enclosure over the surgical site. And this is Panesar's group in Great Britain. One of the things that they recommended was actually a trauma pod. And this is their artist conception of this. you actually have a specific area of the vehicle designed to be an operating room. And again, this is not for missions to the ISS or to the moon. This is for exploration class missions to Mars and beyond. But this may be the kind of solution that we're looking at as we're sending large groups of colonization people to Mars or beyond. This may be a potential option. This is the British Journal of Surgery. So I will stop there a couple minutes early. Just in conclusion, aerospace medicine and anesthesia, I always tell people that it's the same physiology, but different goals. In the operating room, I use physiology to make sick people healthy. But in the aerospace world, I use physiology to treat extremely healthy people that are in lethal environments. So I will stop there. And Jeff, again, thank you for inviting me.
Keith, thank you. Awesome talk. We've got a bit of time, so I'm going to ask you one of the questions that was posed just to save a bit of time later on in this panel session. And that is, do you think, this is from Arma, do you think there is a role for ICP monitoring for astronauts in space, particularly on missions like to Mars, for example?
That's a good question. Again, the data that we have right now is from long duration missions on the International Space Station. So we do have data from a year or more on the space station. And it doesn't seem that there's any initial long-term effect. Again, if there's head trauma, if somebody has head trauma, I can only imagine that the head trauma would exacerbate intracranial hypertension if it were to already occur. But so far, at least with a year or more of experience on the International Space Station, there doesn't seem to be any long-term adverse effects other than spaceflight-associated neuro-ophthalmologic syndrome.
Thank you. I think, Michael, if you're able to start a little earlier, I will give you that opportunity.
Very
Keith,
good.
thank you very much. So I'd like to introduce our final speaker during this Charlie session, and that's Professor Michael Murray. He's a professor at the Banner University in Phoenix and a retired US Army Reserve Colonel. Michael, over to you, sir.
All right, can you see the screen all right?
Yes, we can.
All right. So as everyone else has done, I will thank Jeff for inviting me for this meeting. I've been present since early this morning. I've learned a great deal and enjoyed a great deal. And mine is on mass casualties following shootings and explosions. That's straightforward. And since everyone else did a show and tell where they worked, so this is Banner University Medical Center. This is a new tower over here. Obviously, there's mountains around Phoenix, as you might expect. And the hospital is actually very close to downtown. You can't appreciate that in the one picture. It's right on the Interstate 10 coming through Phoenix. 5 blocks away is downtown. We're an underserved area in Phoenix, if you can believe it. And if I was a kid, I would love coming here because the trauma bay is exciting. There's always a lot of fire trucks or police cars for obvious reasons. And then you can see ambulances in there thrown as well. But I didn't get any of my experience with trauma in a civilian hospital. Mine was courtesy of the US government and the taxpayers. So that's where my experience in trauma comes. And I want to segue just for a moment to thank again the organizers for inviting me because I love these virtual meetings. So I've been at the hospital all night, but when I looked at 3:30 this morning, I could enjoy winter, 45 degrees. But as you see later on in the day, it's going to be 70 degrees. And people say, well, you got to put up with the summers. And yes, you're right. In the summertime, I drive to work with the top down. And in the afternoon, I drive the top up. And now in the wintertime, as cold as it is, I just do the reverse. But there's other reasons for virtual meetings because, as Dr. Wilson has already alluded, Chicago is not the safest place in the world to visit. So my son-in-law, who went there, and I couldn't understand why, but he said they had a good economics department, I guess. He told me the only way to fight it is to join a gang, and he did okay with it. But the gang that he belonged to had some weapons that I really didn't have as an Army physician. So he did okay with that, and I did okay staying away from Chicago and the South Side unless I had to go. So my objectives here are, number one, if I was talking to Dr. Wilson, how are you going to train your department to stay abreast of developments in trauma anesthesia, how to manage mass casualties? And the second goal here is how are you going to educate them for a blast injury should something happen, at the Chicago Stadium. The Bears are playing the Vikings, for example, and someone decides to detonate something. And then finally, what are you going to do if you are the manager of this scenario in a new program? How are you going to design a plan for responding to emergencies, as you know they will come? So why this particular topic? This study is, or I guess more of an editorial, is 15 years old. And the point of it is that as civilian physicians, we need to prepare to manage the kind of casualties that once were only seen in combat. And I've given this presentation or something similar with it on several other continents, and people will speak up as they have in South America. With the drug gang wars, we've seen the same kind of injuries you see or saw in Afghanistan and Iraq. And the same is going to be true more and more so in the United States, as I plotted on this slide, both in terms of the number of shootings in the United States, and though IEDs aren't as commonly used in the United States as they are worldwide, and you can see here they're going up exponentially worldwide. But as Christopher Wray presented, head of the FBI a couple of years to Congress, there is increasing concern that drones will be used. They've been used in South America. They're used by the US government in Southwest Asia or the Middle East, as the Israelis have as well. And the number one injury that they see after these attacks has to do with amputations, and similar what we dealt with when we were in Afghanistan. So my objectives, again, how are you going to plan this mass casualty training for your department? So I guess first we have to define what is a mass casualty. And if you're in a level 1 trauma center, a trauma alert once an hour, a couple times the hour is not unusual. And the system is set up so that you can handle the burden of trauma. I mean, it barely budgets things. We have 2 trauma teams because of the amount of trauma that we deal with at this hospital. And then a trauma incident is one in which it challenges the system, but the system can deal with it. And the thought that comes to mind is at the University of Arizona in Tucson 10 years ago, last month in January, when Congresswoman Gabby Gifford was shot, and there were several people killed. And I talked to some people down there. I said, oh, it really didn't overwhelm the system. Well, there were only 11 casualties. I can't say only, but it is a level 1 trauma system. And so they were able to handle that without any problems. A mass casualty event is where the system may overwhelm the hospital. And an example of that would be the Las Vegas shooting 3 years ago, last October. But I think that's all, who cares? You know when your system is going to be challenged. So I just prefer to call it a mass casualty situation that you might have to deal with on a very short notice, as I'll discuss subsequently during these presentations. And it's not just the number of casualties, there can be other things that might happen. You could have a lightning strike. And does it happen even at Mayo Clinic Rochester? Long story, but lightning bolt hit a power line and it took out the electricity for all of Rochester, and all the emergency backup generators that the clinic had set up failed. You could have a tornado, as happened in Joplin, and though only one hospital is knocked out, the other hospital had to deal with not only the casualties that were coming in, but all the patients who were being transferred from the other hospital. You can have a flood. And I was at the Texas Medical Center when it flooded. And at that time, they never anticipated that the floodwaters would get so high that it would flow over the barriers into Methodist Hospital and fill both the sub-basement and the lower basement, and all those electrical lines going through the basement shorted the entire hospital out. And in Houston, none of the windows open because it's all air conditioned, but there was no air conditioning. There was 3 feet of water outside of the hospital. So things like that happen. They can challenge a hospital system. And finally, on the West Coast and up in the Northwest, you can have earthquakes that take out hospitals. In the Northridge Hospital, there were 8 hospitals total, 4 of which were taken out of commission. But patients don't know that. They see hospital, they go there. If they're injured, hopefully they won't be injured by gunshot wounds, but you never know. So in preparing your department, what are you going to do? You got a new program. You want to make sure that not everyone is going to be a trauma anesthesiologist, but they should know the basics. As Dr. Dutton said in his presentation, one of the myths is that anyone can do trauma. Well, it's an argument, and I'll get back to you subsequently here, when wrote an article with Ron Miller a couple of years ago about the role of the acute care trauma anesthesiologist. And at the House of Delegates of the ASA, statement was made, we all know how to take care of trauma. And that's not true. In order to be as familiar with a proper study as Avery is, then you need someone in your department that is going to share that information and implement those programs with your department. So you have those sorts of exercises, and then you can have a discussion based. And what I did prior to coming here 18 months ago, I was up at Geisinger Clinic in Pennsylvania at their main teaching hospital. And for our grand rounds, once a year, I would have a presentation on trauma anesthesia. Doing a workshop was a little more of a challenge because it really wasn't supported by the department. The thinking being, it's never going to happen here. Well, it does happen here. And then we could do a tabletop exercise. How are you going to handle these sorts of scenarios? And I'll give some examples of that subsequently. Now, what about having the department included in the biannual hospital emergency response? I've never been anyplace, and I've asked, there's no way to do this here, but I've asked people when we're doing face-to-face meetings, how many people have actually participated. About 10% of the audience will raise their hand, but their participation may have been during the drill to go to the emergency room and then come back and coordinate some moulage patients to the holding area, for example, just to go through some steps. But in terms of a true emergency response, I have rarely seen that effectively utilized in the training department. And this happened also when I was up there. I was looking out the window from the intensive care unit on a Saturday like today. And I saw this outside, and I grabbed my residents and we went down there. And I said, what's going on? And he says, oh, we're doing a drill where a train of poisonous nerve gas agents derailed. And we're just decontaminating him and taking care of him. I said, why weren't any of us notified? Well, we just assumed everyone would be here. You don't have to be involved. Well, these are emergency response personnel. There's no physicians. There's no acknowledgement that we might have to do something differently in the hospital. And so no one had to prepare. I didn't have to prepare to empty out my ICU. The operating rooms didn't have to call anyone in. I didn't see it as very effective. And then there were other issues. At Walter Reed, whenever they do their disaster drill biannually, they never do it during a weekday. It is always on the weekend because no one can get in from home trying to get through, navigate the Beltway. And then likewise, when I was in Germany at Landstuhl, you always had a week's notice because they would provide daycare for you so that you could participate in the drill. So how realistic is the training? I don't think so. So then what else can you do? You can learn from smaller incidents. And we've done this many times, again, up in Geisinger. Had 3 patients die in the operating room following a traumatic injury, and we reviewed the charts. And the surgeons were somewhat comfortable with the fact that the patients were hypothermic. And I said, this is malpractice. They came into the OR at 36 degrees. They came out at 32 degrees. We've got to do a better job. There's a lot of resistance to that because the people who are involved said, well, I did the best I could, but that's not enough. So when you're doing these exercises, it needs to be emphasized to everyone. And I think last year, prior to COVID hitting, the president of the ASA was going around, and one of her emphasizing points was the necessity of maintaining patients' body temperature intraoperatively. So there's other things you can do. You can do, as I mentioned, different exercises. You can do an MMM of a more major traumatic event. We have several patients coming in. You can practice simulation with PPE. You can do simulation donning and doffing PPE equipment. What I hear is, oh, we know how to do that. We did it during COVID. And when I watch people, I think to myself, boy, if you managed a patient with Ebola the way you're managing this patient, half of our hospital staff would be dead. I mean, the habits that have become very prevalent over time are not something to be proud of by any means, because when the balloon goes up with Ebola or something worse than COVID, we're going to be at a disadvantage because everyone will need to be retrained. Now, as part of your plan, you need to come up with a way to communicate with your faculty. So if you were on a Saturday and something happens, what are you going to do? The Federal Trade Commission says that you should not rely on networks. In the World Trade bombing in 2001, the networks went down almost within minutes for a variety of reasons. Number one, the towers coming off of the Twin Towers, the communications towers went down, and then there were so many calls logging you couldn't get through it. And then, so in this particular article, for which I wrote an editorial, they developed a SMS text messaging system. So all they had to do was push one button and a message went out to everyone. Good way to do it. The problem is everyone called the operating room control desk to find out, do I really have to come in? Is this a drill? I mean, what are we doing? You need to deal with those issues within your department and address the department, and at least a biannual or an annual program that emphasizes to people what is going to happen if they're called in during an event. Transportation becomes an issue, and I have some slides from Dr. Dutton from the Las Vegas bombing in October of 2017. And as I will show you on a subsequent slide, the roads were closed. How do you deal with bringing your hospital staff in if half of the city is cut off from the hospital? There has to be other workarounds with which you deal. When I lived in Jacksonville, Florida, and I was the chair of the anesthesia department down there, I knew that if a hurricane struck, I would have to leave for the hospital about 24 hours before, you know, the eye got anywhere close to land, because all the bridges in Jacksonville would be closed because the winds were strong enough to blow cars off of it. So that has to be taken into account. The people in your department have to have a plan for how they're going to get in. In the Tokyo sarin attack many years ago, St. Luke's Hospital there, within the first hour after the attack, 500 people showed up in the emergency department, long before anyone at the hospital knew what was happening. And reverse can be true. So in the Chechen bombing in Moscow in 2002, the security forces pumped some sort of agent in the air vents. Everyone thinks it was carfentanil. And the problem was they didn't clear the streets in advance because they didn't want to alert the terrorists if something might happen. So it took the ambulances an hour and a half to get there. And then to make matters worse, they didn't tell anyone that carfentanil was used or an opioid was used. They thought it was a nerve agent. People were getting atropine when they should have gotten naloxone. Long story, but transportation was there an issue as well. So we next move on to, you've developed whatever program is going to work for your department in terms of training, to understanding the mechanisms of blast injury. And so physics of a blast are fairly straightforward. You've got a explosive agent, something like C4, for example, or TNT. You've got a detonator, and once that detonator goes off, it ignites, you get a primary blast wave, and then you have, as that blast wave goes out, then it comes back, a negative wave in a sinusoidal fashion, though the negative wave does not have the force as the wave going out. And then you also have the blast wind that follows after that. Now, what's the difference between the shock wave and the blast wave? Well, once the explosive detonates, there is almost an instantaneous, we're talking in milliseconds, for that shock wave to be dissipated. After that, the heat that is generated from the explosion warms up the surrounding air, and then that creates the blast wind that follows. So the question, and we don't have a good way to do this, at least I haven't figured it out yet. In this particular individual, and we're looking at this 2-year-old here who was injured by a concussion grenade, and this happened in Iraq, had an injury to his colon, and because the colon is air filled. And so what is the mechanism that accounts for that? It's a primary mechanism to which is alluded, and that is from the blast wave impacting air-filled structures within the body. And so the ear, colon, the lungs. And at one point in time, I used to show a slide where if you were screening a number of patients from a bombing event, let's say the Boston Marathon, if you put a pulse oximeter on and the saturation was good, you did a otoscopic exam and the eardrums were intact, shouldn't have sustained too much injury. But in the Madrid bombings and the Boston Marathon bombings, people could have significant injuries and yet still have intact eardrums. So that's why we're not showing the slide today, because there's no basis for it. So I like this slide for a couple of different reasons. Number one, it demonstrates the different mechanisms. So number one is a primary injury mechanism, which is just from the blast wave. And then the secondary one is due to the blast wind picking up agents, or if the weapon itself, the device, contained ball bearings or ceramics or anything that is designed, a grenade, for example, to penetrate and cause penetrating damage. And then depending on how significant the blast, the individual can be blown up into a building, or the building can be blown or toppled over the individual. And so you have a blunt trauma with which you have to deal. And then what this particular slide is emphasizing is that you can also have blast injury to the brain. And until I deployed, I didn't appreciate those factors until I saw a significant number of servicemen with it. And injury to the colon and the lungs from the blast wave itself, that's relatively unusual. It would almost be considered rare. But in terms of this injury to the head, and it comes about from a combination of things, the soldier's helmet will focus the blast wave, will contain the heat, whatever heat might be there. And then the wind will also have this counter-toe mechanism that where the brain is pushed back and then comes back over. And ultimately, in a significant number of soldiers that I saw, this was a mechanism whereby they stayed in a persistent coma for some period of time. Typically for the trauma surgeon, oh, he hasn't recovered from anesthesia yet. I said, it's been 2 hours. These are young men, women. It doesn't take them too long, 2 hours to recover from anesthetic. There's something else going on. So then you have combined blast injury, which would be the fourth mechanism. And there's also people will consider a fifth, but that's kind of a nebulous entity, if you will, due to some of the chemicals that might be released. And in terms of a combined blast injury, there could be any other three mechanisms involved. And also because of the heat that's generated, you could have a burn injury. And there is a reason that the original formulas for resuscitating patients of the two that were prominent in the United States many years ago, the Parkland formula and the Brooke Army formula, was because the Army's major burn centers in Brooke Army. So there's another thing that you have to recognize about blast injuries, and one blast is not the same as any other blast. So this is a young Marine who was injured in Iraq. And at that time, when we were more involved in Iraq, we had 150 soldiers who had their faces, scalp completely burned off. They tend to reside in San Antonio. The Army hasn't yet moved forward with the facial transplant program for them. But the reason those injuries are much more prevalent was because they were riding around in Humvees. If you attack a Humvee with a rocket-propelled grenade, it enters, it explodes, it focuses that blast wave, resonates off the wall, and then it also contains the heat. So then when I deployed to Afghanistan, I expected to see the same, and there nothing could be further from the truth. It was a completely different kind of injury, and I'll explain that later. So now this is an article that appeared after the Boston Marathon bombing, and it emphasizes that the survivors of the bombing benefited from the experiences that were gained by the military. And military medicine and the lesson we learned in Iraq and Afghanistan, major influence on how victims were treated. And it gave, I thought, undue emphasis to military medicine. Now, my nephew was chief of trauma at Brooke Army Medical Center, just retired 2 years ago. And he may have been trauma consultant to the Surgeon General, but his wife was already the surgical consultant to the Surgeon General, the Army Surgeon General, so that couldn't happen. But when he was in this situation, and I was challenging the both of them about Army medicine, I said, Kurt Edwards was his name, you didn't train in the Army for trauma. You went to Maryland Shock Trauma for your trauma experience. And now that helped you when you went over there, but it wasn't all by the grace of God and the grace of the U.S. Army that you are the person you are today. And this goes back for hundreds of years. And this is a World War I casualty who lost his lower mandible, his lower face. And for reconstruction, they weren't doing free flaps then. They were done by a plastic surgeon who still has several procedures named after himself, Sir Harold Gillis. And I don't know if people know the story, but his anesthetist was Ian McGill. And McGill developed McGill forceps for a reason. You can't do open drop ether on the patient who I just showed you. So what he did, according to the history books, he went out to the garden, cut some hose, stuck it down the patient's trachea after anesthetizing him with open drop ether on a mask, and then tucked with his forceps cotton around the hose that he stuck down there, and then he would run that hose off to the side and then put the mask over the end of the hose. So some of the development of tracheal tubes, for example, were created by anesthetists to treat war casualties following World War I. And the story gets repeated many, many times subsequently. But anyway, in the Boston Marathon bombing, I think everyone pretty much knows the story. The outcome is that there were 264 individuals who were injured who went to 29 hospitals. And that underscores the fact that some people just got into a car and went. The more severely injured patients went by ambulance, and they were transported to the level 1 trauma centers downtown. And then 3 were killed, and they were, I can show the actual pictures of the actual bombing, and it was the individuals immediately around the 2 devices that exploded. And then 16 patients had traumatic amputations, either at the site or at the hospital if they were unsalvageable. And of the 16, 3 had more than 1 amputation, or had lost more than 1 limb, I should say. And it duplicates what was the experience in Afghanistan. In Afghanistan, service members were not patrolling in Humvees. They were out on foot. They use a rotor wing or a Humvee or whatever to get out to the site, but then they would patrol on foot. And so in this color here, these are single amputees, these are double, and these are triple. And the chart displays, I think, graphically what the experience was in Afghanistan compared to what the experience was in Iraq, where you had a lot of burn injuries. Here it was more traumatic amputations. And for every limb that is considered non-salvageable, this was the occurrence in Boston as well, you have 5 severely injured extremities. This woman maintained both legs, but at the same time enough injury to her legs that she subsequently had to go through rehabilitation to regain her mobility. And if you have a traumatic amputation that takes off both lower limbs, it creates a lot of other damage. And the thing about Boston is these were relatively crude devices. They occurred out in the open. If they had been packed with more explosive material, something other than nitrogen or fertilizer, or if they had been in a contained space, the injuries might have been very different. So the lessons or experiences we had dealing with explosive injuries or gained on the battlefield. And in this particular slide, you'll see those individuals who sustained injuries that were non-survivable, either to the head, to the torso, or to more serious injuries to their bodies. But where we want to focus on up here are those who had injuries that were survivable. And from that, the military has developed a number of protocols that move forward. This is a study that I did with John O. I was a senior author, just looking at injuries that came into a facility, World 3 facility down in Afghanistan. And Rick Dutton mentioned it this morning at Maryland Shock Trauma. The experience was if you arrived with a heartbeat, you had a 98% chance of survival. It's pretty remarkable what has happened in military medicine because of the symbiosis between the civilian side and the military side. You have Dr. Wilson coming back and several others who have shared their experience with us, who have that sort of training, and many, many trauma surgeons at U.S. hospitals receive their training in the Army. They have done their fellowships at places like Shock Trauma in Houston, Harborview, but the real experiences with trauma anesthesia were in the battlefields in Iraq and Afghanistan. So with that, the major causes of preventable death, obviously, are the airway, tension, pneumothorax, and bleeding. And so for the airway, all medics carry around a nasal trumpet. 1% of deaths were from loss of airway because they were unconscious. Everyone, and I joke about this, when one size fits all in the military. So training at Fort Bennett one time before heading over, or Benning, excuse me, we were all practicing putting needles in the second intercostal space. And I joked with the people there. I said, I wish I could teach anesthesia residents to respond this way. When I was an examiner for the oral boards and you gave them the scenario of decreasing SpO2, and I'll say, did I ever cross? Okay, the patient is in the morgue. Are you going to put a needle in this pneumothorax? You're just going to let him die. Please do something. The medics and E4s in the military are far more ready to put a needle in the pneumothorax than others. And then the issue with tourniquets that have been presented multiple times, and the use of it in the Stop the Bleed program that the American College of Surgeons has developed. So getting back again to the role that anesthesiologists have done, who started the entire discussion of resuscitation from traumatic injury. This is one of Ron Miller's original papers. He was a Berry Plan physician during Vietnam. And he and I have talked about this subsequently, and he had this reputation, oh, here comes Doc Miller. And he would crawl under the tents, and he was drawing blood on everyone to figure out why they were so coagulopathic. And at that point in time, it was considered delusional coagulopathy secondary to dilution of platelet counts, also discussed earlier. So now then, let's finish up with this, talking about how you are going to design your department's plan. So we got this department, University of Chicago, and program, you're going to be managing casualties. We're talking about a major event at the Chicago Stadium. I think that's maybe 4 or 5 miles away. So let's start out with the first scenario. You're on call on a Saturday, not necessarily at the University of Chicago, let's say just a level 2 hospital somewhere else. Just you and a resident or a CRNA, and you get a call, there's been a shooting, and the ED calls, we got someone down here with a gunshot wound to the leg, and you go moseying down there, big deal, what's the gunshot wound to the leg? Well, it just depends. One gunshot wound is not the same as every other. And my point here is if you can see air through the wound, that's usually not a good sign. And this individual was a Polish soldier treated in Afghanistan in a helicopter fired at by 50 caliber round. I really don't know any of the details, but this is not an M16 round by any means. And he had 3 massive transfusion protocols. I saw all of his records, 10 units in the morning, took him back another 10 units, and in the afternoon, 10 units, and it was all the 1-to-1. He arrived in Germany, and within a day, he lost his leg. doesn't see anything to be salvageable, but downrange, you can get focus. And I'm going to mention that you can't, if you have significant number of casualties, you can't focus on just one patient. Good medicine may be bad medicine. You have to maximize your capability to support as many patients as possible. Second scenario, now it's not one person. You got two guys show up, and now one of them got a gunshot wound to the legs. And here's this scenario. Not a 50 caliber round or both legs would be gone, but a significant round. And you say, well, where's the other guy? I want to find out what happened to him. Well, the other guy was shot as well. So the round came through this leg, and ended up in his brother's leg. And this is the round that they retrieved from that leg. And treatment of this one was relatively easy. He gets bilateral, the stumps were cleaned up, amputated, moved on his way. He was out of the hospital the next day. His brother, on the other hand, we didn't pay as much attention. And I think you can just see the faint image of a saddle embolism. I mean, he survived, but he ended up staying in the hospital for a much longer period of time. So that's kind of a overemphasizing things, but most gunshot wounds are single events, single shots, and I've got data I'll share with you. But when I went to medical school, this individual, doubt many of you recognize him, this is Ken Maddox. He was 9 years ahead of me in medical school. So given his 5-year surgical training, when I was a junior medical student, he was just running the Bentop emergency room for about 3 years. And my nephew again tells me he is a granddaddy, or one of them, in trauma surgery in the United States. And one of the things he emphasized, and I remember sitting in our little amphitheater listening to him lecture, is that you need to understand what your patient was shot with. 50 caliber, they're going to either be dead or the extremity is going to be gone. But if you start looking at some of these other weapons, the 303 round, for example, versus the 22, that's something you need to know about when you're managing casualties. And then on this particular slide, because I emphasize the role of the tourniquets, this is a study done by some individuals at Mass General. And I think to myself, Mass General, they might as well be at the Mayo Clinic in the middle of nowhere, Minnesota. But they didn't look at casualties in Olmsted County, Minnesota. They went to New York and they pulled all the data for the state of New York. And they found over 27,000 gunshot wounds in 25,000 individuals with a mean age of 28. 89% were men, 54% were Black. 84% of them went to a major metropolitan hospital. So this is a large city event. And what they found is that only 1.8% of the patients had a vascular procedure to an extremity. These would be the individuals who might benefit from a tourniquet. Also out of this, similar to what Dr. Dutton presented, maybe not shock trauma caliber, but 2.8% of patients died in the emergency department. And then a more recent study looking at civilian public mass shootings in the United States found that only 3% of victims died from an extremity wound, 51% died from thoracic wounds. And that doesn't mean that 51% of individuals who are shot in the chest are going to die. It just means that of the people who died, it could have been 55% had a thoracic wound and 98% of them died. But overall, 51% of the patients who died had thoracic wounds, and the other had gunshot wounds to the head. And the conclusion of these studies, and somewhat controversial, appeared in the surgical literature. Why are we spending the amount of money that we are on Stop the Bleed? Could that money be spent better elsewhere, i.e. studying mechanisms of injury or how to prevent those injuries? And Dr. Dutton and I were on a panel last week where we discussed whether or not the ASA, and I know Armand feels very strongly about this, Armand Daigle up in Harborview. Well, I think we all do that. We're not talking about gun control. We're talking about how to decrease the number of deaths. So in this particular slide, and I'm switching over to the Las Vegas shooting, and
Mike, do you think it would be possible? Mike, sorry, do you think it's possible to wrap up?
Staff of Sunrise Hospital, and this is a timeline, and the event occurred at 22:05, and within 20 minutes, you've got the first patient arriving by private vehicle before the ambulances even came. And then you activate, you activate the system, and by midnight, 2 hours after the event, you've already completed 5 surgeries. Sunrise Hospital, level 2 hospital in Las Vegas, because the ambulances couldn't get to the level 1 hospital because the strip was closed. That's the thing you have to deal with, and how they dealt with this. And by the midnight the next night, 26 hours later, they had 56 surgeries completed. And it's a very interesting dynamic of how they dealt with that. So in managing these mass casualties, you have to—
Michael, can I ask you to potentially wind up, please?
You have to keep it simple, get as much help as possible. Don't get bogged down with one patient, as I mentioned, because good medicine may be bad medicine. Keep your head above the smoke. And in identifying a leadership, it may not be the most senior member of the department. In surveys that have been conducted, you want someone who is a problem solver, who can communicate, who's calm under pressure, who's flexible, who is creative. And your responders, a different set of attributes, but your leaders, people are going to be managing this. And the go-between between the ED and the operating rooms, however you define it, has to have those skills. What kind of mechanisms? We've alluded to that. Are you going to use STS? If everything is out, what's your communication plan? Do the members of your department know they just need to come in if they're aware of a mass casualty event? What do you do for anticipating arrival? Have you discussed with your EMS, they're going to triage, or are they going to bring in the patient right away? Now, after the studies that Maddox conducted in 1994, we know it's scoop and run. You don't want to give a lot of crystalloid. What about the people points of injury? Are the security guards going to shut down the points of entry? And if so, how are your physicians and healthcare providers going to get into the hospital if they forget their ID? Should you send someone down to the door to help them navigate? And then what about triage? And this is in a non-combat civilians. They want to put everyone in the operating room right away. In a military environment, not quite as bad. And with time, they're much more likely to become experienced enough to know who can be delayed. And what do you do if you get pediatric patients? So time must be up. So with that, I will hurry up and finish this about the role of anesthesiologists. We've got multiple roles in the operating room. And then my daughter and Ron Miller argue that the time has come for a critical care anesthesiologist. There was a lot of pushback within the community. We talked about the anesthesia community, Mark Warner at Mayo and Jeff Applebaum there in Chicago, about why, how we could do this, but it never happened. So with that, I will conclude and turn it back over to Jeff and who's ever up there in Chicago.
Thank you, Michael. Gentlemen, Charlie session, if I can get you all to, or Michael, first of all, to stop screen sharing. And then we'll ask.
Okay. Stop share, there we go.
Yeah, okay. Thank you. Okay. So, gentlemen, I've got a few questions that have been posed by the delegates. Keith, I'm going to start with you. So, are there any issues with surgical fires whilst on space flight? And that's from Albert Baron.
So obviously surgical fire would be a catastrophic event that could potentially endanger the life of everyone aboard. Actually, any kind of aerospace fire is one of the dreaded things that you do everything you can to prevent. One of the things that's come of our experience in spaceflight is up until Apollo 1, what was used on spacecraft was 100% oxygen and at reduced pressure. And the Apollo 1 fire, which killed all aboard after that, a different strategy was used. Believe it or not, on the International Space Station, they breathe a gas mixture very similar to that on Earth, 21% oxygen at sea level pressure. So there's no additional risk for a fire just because of the composition of the atmosphere, as there would be if the astronauts were breathing enriched oxygen and reduced pressure. But that said, you want to take every step possible to mitigate the risk of a surgical fire, because that, again, can jeopardize the entire mission.
Thank you, Keith. Avery, I've actually got 4 for you, so I'm going to choose some of the better ones. This one's from Paul Ballard to you, Avery. Is it time to give up on the RCT, null hypothesis, testing frequentist paradigm, and look at the Bayesian models to answer these big questions?
You know, that's a good question. I've often thought to myself that tactically, you know, those who design big multi-center trials, you know, are intentionally targeting big enough that everybody thinks they found a result, and then they can, you know, they've gotten what they wanted, which is to change clinical practice. I definitely feel like Andromeda Shock feels like that kind of trial. If you haven't read it, go back and read it. You know, the authors are on Twitter saying, we thought we had a positive trial, but JAMA forced us to say negative, which I think is very interesting. I don't know that Bayesian strategies are any less subject to human bias and interpretation than non-Bayesian trials. You know, if we're going to be evidence-based, we have to sort of put our, you know, sort of hooks in the ground somewhere. As long as we don't make, and as long as we allow some human interpretation of the link between what the evidence says, so to speak, and, you know, what we actually do clinically, you know, then I think that's fine, personally. I also, you know, sort of sometimes feel like a lot of medicine is very dynamic, and studies that were true 10 years ago and 5 years ago may not be true now. And certainly guidelines, you know, have sunset limitations on them, and partly for that reason.
Thank you. One from Dr. Varon. Let's find it. Here we go. Any suggestions as to how to control the one-to-one-to-one epidemic on non-trauma cases during surgical bleeding?
Dr. Barron, that is a great question, and I got that at 12:30, and for the last half hour I've been pondering how to study that question, because it maybe there is one, and how would you pull that out of, you know, a large database and then put that out there so we know that it happens? I imagine that would be the first step, studying it, you know, and documenting that the event actually occurs, you know, and then I know that there are many unpleasant ways to make that not happen. For example, our blood bank is very stingy with their platelets. They'll give you 1 unit, but then you have to beg and they will ignore you. Then you have to beg again, they will ignore you again. Then you have to send all kinds of tests to show that it's not something else that you could fix. I do think better communication in the OR may also help. You know, if the surgeon says, no, we don't need platelets, we're fine, you know, I feel like that's very reassuring to me as an anesthesiologist, because they're in there, they see it, they know what's going on, and unless I don't trust them, you know, I feel like, you know, if they're on my side, then, you know, we can both have a consensus idea that we don't need to give anything more than we need to give in terms of FFP. Everybody, as I do observe, you know, I ask our residents, because I only practice myself, so I don't know what everybody else does, but we all have our number. You know, the patient is bleeding, you give 1, 2, 3, 4 units of red, and somewhere in there you start thinking, should I give more FFP to go along with this blood? And that number, at least in our institution, you know, at least told to me by residents, varies between sort of 4 and 8. But now you've given me an idea. I'm going to go back and see if I can figure out exactly what that number is, you know, and whether it has shifted since the publication of Proper. That's really interesting.
The next question, again for Avery, and that's from Rick Dutton. What's the potential future use of cold stored platelets, either alone or as part of whole blood storage?
You know, Rick's a smart guy, you know, and he has a sort of is, I guess, keying on the observation that cold stored platelets seem to work better than warm stored platelets. And there are sort of many, actually multiple publications in the literature now finding that they seem to clot better. You know, we have an ongoing controversy in our department as to whether you should turn off the warmer or give your platelets through a non-warmed line, because warming the platelets makes them not work as well. And, you know, there are arguments and counter arguments, and there was even a resident talk, you know, in our department on, you know, myths in anesthesia. And one of the myths was that if you give platelets through a cold line, then it works better. My read of the literature is that there may be some, preclinical lab data saying that, platelets look different when you cool them down. But whether that clinically affects the clotting behavior is unclear. My own personal practice is to not turn the warmer off when I give platelets because it's just something I might forget to turn back on later. I believe that, cold stored platelets may very well help our ability to transfuse whole blood because one of the biggest issues once you get past the immune thing is that the platelets deteriorate over time.
Gentlemen, thank you. I have no other questions to ask you as a bunch of panelists. So I'm going to thank you all for your contributions, everybody who's participating.
Hey, Jeff, can I ask Keith a question?
Certainly, Mike.
Keith, you mentioned this woman who did a breast biopsy on herself. When I was in school, one of my colleagues went to Antarctica and he had a prophylactic appendectomy because he knew at certain times of year couldn't get back. Are people still doing that, or is that just a case-by-case scenario?
I think it's a case-by-case basis. People have talked about that, but to my knowledge, at least for the ISS, nobody does prophylactic appendectomies. I don't believe they do for wintering over in Antarctica either.
All right. That's warming up there so much, I don't need to worry about it anymore.
That's true. Pretty soon it'll be like North Carolina.
And I'm gonna have beachfront property here in Arizona.
Yeah, there you go.
We have come to the end of our allocated time for this trauma, anesthesia and resuscitation webinar. So I'm just going to hand you all over to my chairman and co-organizer for this meeting, Dr. Nagley, to finish with his remarks. Thank you.
I want to thank everyone, for, it's like 6 hours of intense trauma discussion. I thought it was absolutely superb and outstanding. Really wide variety of interesting topics. I think this is a clear sign that we need to do this again next year. And the plan is, as Jeff has posted here, to do this around St. Patrick's Day weekend, where the city is in green, in Irish green, and it's probably the climate a bit warmer. Thank you all for attending. I honestly think this was just a resounding success. Thank you for all the speakers. It seems like we have a heavy committee from Harborview, and really outstanding. Then we'll see you in a year from now. Thank you very much for joining us and making it all the way through the end. Thank you all.
One comment, we had 94 delegates at one point.
This is just outstanding.
Very good. Congratulations.
Thank you.
Thank you all.
Okay, I'm going to end the meeting. Thank you, gentlemen and ladies.